The Subcommittee on Health will reconvene our hearing on comprehensive health care reform on the discussion draft. And we have actually 4 panels today, and we're going to get started. So our first panel is on Medicare payment. And let me introduce our two witnesses. First on my left is Glenn M. Hackbarth, who's the chair of the Medicare Payment Advisory Commission, better known as MedPAC. And then next to him is the Honorable Daniel R. Levinson, who's the Inspector General for the U.S. Department of Health and Human Services. We're starting fresh today. If you had been here at 7 o'clock last night, it wouldn't have been as, we would have all looked very tired, but now we're all fresh. So, you know the drill. We ask you to talk about 5 minutes, and your complete testimony becomes part of the record, and then we'll have questions. And so we'll start with Chairman Hackbarth.
Thank you, Chairman Pallone and Ranking Member Deal, members of the subcommittee. I appreciate the opportunity to talk about the Medicare Payment Advisory Commission's recommendations for improving the Medicare program. As you know, MedPAC is a nonpartisan congressional advisory body. Our mission is to support you, the Congress, in assuring Medicare beneficiaries have access to high-quality care while protecting the taxpayers from undue financial burden. MedPAC has 17 commissioners. 6 of the commissioners are trained as clinicians. 7 of the commissioners have experience either as executives or board members of healthcare providers or health plans. 3 commissioners have high-level experience in congressional support agencies or CMS. And we have 4 researchers who add intellectual rigor to our work. And some commissioners have more than one of these credentials. In addition to that, we have a terrific staff headed by Mark Miller, the executive director. I want to emphasize the credentials of the commissioners, to emphasize that we are from the healthcare system in no small measure. As such, MedPAC commissioners recognize the talent and commitment of the professionals who serve within the healthcare system. We are not outsiders, critics who have no appreciation of the challenges of being on the front line. MedPAC recommendations may be right, they may be wrong. The issues are complex and rarely are they clear-cut. But if we're wrong, it isn't because we are inexperienced or lack a stake in the success of the system. We also take pride in our ability to reach consensus on even complex and sensitive issues. For example, in our March 2009 report, we voted on 22 different recommendations. On those 22 recommendations, there were roughly 300 yes votes and only 4 no votes and 3 abstentions. All of the MedPAC commissioners agree that Medicare is an indispensable part of our healthcare system. Not only is it financed care for many millions of senior citizens and disabled citizens, it's helped finance investments in healthcare delivery that have benefited all Americans. But we also know that Medicare is unsustainable in its current form. We must slow the increase in costs even while maintaining or improving quality of care and access. We believe accomplishing that task will in turn require both restraint in payment increases under Medicare's current payment systems and a major overhaul of those payment systems. Medicare's payment systems, and I would add those used by most private payers, reward volume and complexity without regard to the value of the care for the patient. Moreover, those payment systems facilitate siloed or fragmented practice, whereby providers caring for the very same patient too often work independently of one another. When care is well integrated and coordinated, it is usually testimony to the professionalism of the clinicians involved. That coordination and integration is too rarely supported or rewarded by our payment systems. The resulting fragmented approach to care is not only expensive, it's dangerous, especially for complex patients, of which there are many in the Medicare program. It's MedPAC's belief that we need payment reform that rewards the efficient use of precious resources and the integration and coordination of care. But it's not enough to simply change how we pay healthcare providers. We also must engage Medicare beneficiaries in making more cost-conscious choices while being sensitive to the complex nature of the decisions that must be made and the limited financial means of many beneficiaries. It's our belief that the cost challenge facing the Medicare program, and indeed the country, is so great that we need to engage everyone, patients, providers, and insurers, in striving for a more efficient system. In the last several years, MedPAC has recommended a series of changes in the Medicare program that we believe would help improve the efficiency of the care delivered while maintaining or improving quality. Let me just quickly mention a few of those recommendations. First is increased payment for primary care services, and perhaps a different method of payment as well. Abundant research has shown that a strong system of primary care is a keystone of a well-functioning healthcare system. Second, we've recommended that the Congress take a number of steps to increase physician and hospital collaboration, including gain sharing that would encourage collaboration between physicians and hospitals on reducing cost and improving quality. Third, we've recommended reduced payment for hospitals experiencing high levels of potentially avoidable readmissions. As you know, about 18 to 20% of all Medicare admissions are followed by a readmission within 30 days at a cost of roughly $15 billion a year to the Medicare program. Next, we've recommended a pilot of bundling, whereby payment for hospital and physician services provided during an admission would be combined into a single payment and perhaps combined with payment for post-acute services as well. Next, we've recommended reform of the Medicare Advantage program so that participating private plans are engaged in promoting high performance in our healthcare system instead of offering plans that mimic Medicare.
Mr. Hackworth, I want you to finish, but I just want you to know you're a minute over, so.
Okay. I am to the last step, Mr. Chairman. Let me just close with two cautionary statements. One is that changing payment systems, and we must change them, and doing so with some speed is going to require more resources and broader discretion for CMS than it now has. The second caution is that while we need to reform payment, it's going to take some time, and in the meantime, we need to continue pressure on the prices under our existing payment systems in the Medicare program. Thank you.
Thank you very much for what is really important in terms of what we're trying to accomplish here. I appreciate it. Mr. Levinson.
Good morning, Chairman Pallone, Ranking Member Deal, and members of the subcommittee.
Your mic may not be on, or maybe it's not close enough. Try to move it. No, I think you got to press
Hit the button.
when the green light is on. It's green light on?
It is.
Now you're fine.
Okay, thank you. Chairman Pallone, Ranking Member Deal, members of the subcommittee, good morning. I thank you for the opportunity to discuss the Office of Inspector General's work at this very important time of deliberations over health care reform. Based on our experience and expertise, our office has identified 5 principles that we believe should guide the development of any national health care integrity strategy. And consistent with these principles, OIG has developed specific recommendations to better safeguard federal health care programs. My office has provided technical assistance, as requested, to staff from the committee, and we welcome the fact that many of OIG's recommendations have been incorporated into the House Tri-Committee Health Reform Discussion draft. Principle 1, enrollment. Scrutinize those who want to participate as providers and suppliers prior to their enrollment in the federal health care programs. Provider enrollment standards and screening should be strengthened, making participation in federal health care programs a privilege, not a right. As my written testimony describes, a lack of effective provider and supplier screening gives dishonest and unethical individuals access to a system that they can easily exploit. Heightened screening measures for high-risk items and services could include requiring providers to meet accreditation standards, requiring proof of business integrity or surety bonds, periodic recertification and on-site verification that conditions of participation have been met, and full disclosure of ownership and control interests. Principle 2, payment. Establish payment methodologies that are reasonable and responsive to changes in the marketplace. Through extensive audits and evaluations, our office has determined that Medicare and Medicaid pay too much for certain items and services. When pricing policies are not aligned with the marketplace, the programs and their beneficiaries bear the additional cost. In addition to wasting health care dollars, these excessive payments are a lucrative target for unethical and dishonest individuals. These criminals can reinvest some of their profit in kickbacks, thus using the program's funds to perpetuate the fraud schemes. Medicare and Medicaid payments should be sufficient to ensure access to care without wasteful overspending. Payment methodology should also be responsive to changes in the marketplace, medical practice, and technology. Although CMS has the authority to make certain adjustments to fee schedules and other payment methodologies, some changes require congressional action. Principle 3, compliance. Assist healthcare providers in adopting practices that promote compliance with program requirements. Healthcare providers can be our partners in ensuring the integrity of our healthcare programs by adopting measures that promote compliance with program requirements. The importance of healthcare compliance programs is well recognized. In some healthcare sectors, such as hospitals, compliance programs are widespread and often very sophisticated. New York requires providers and suppliers to implement an effective compliance program as a condition of participation in its Medicaid program. Medicare Part D prescription drug plan sponsors are also required to have compliance programs. Compliance programs are an important component of a comprehensive integrity strategy, and we recommend that providers and suppliers should be required to adopt compliance programs as a condition of participating in Medicare and Medicaid. Principle 4, oversight. Vigilantly monitor the programs for evidence of fraud, waste, and abuse. The healthcare system compiles an enormous amount of data on patients, providers, and the delivery of healthcare items and services. However, federal healthcare programs often fail to use data and technology effectively to identify improper claims before they are paid and to uncover fraud schemes. For example, Medicare should not pay a clinic for HIV infusion when the beneficiary has not been diagnosed with the illness, or pay twice for the same service. Better collection, monitoring, and coordination of data would allow Medicare and Medicaid to detect these problems earlier and avoid making improper payments. Moreover, this would enhance the government's ability to detect fraud schemes more quickly. As fraud schemes evolve and migrate rapidly, access to real-time data and the use of advanced data analysis to monitor claims and provider characteristics are critically important. OIG is using innovative technology to detect and deter fraud, and we continue to develop our efforts to support a data-driven anti-fraud approach. However, more must be done to ensure that we and other government agencies are able to access and utilize data effectively in the fight against healthcare fraud. Final principle, response. Respond swiftly to detected fraud, impose sufficient punishment to deter others, and promptly remedy program vulnerabilities. Healthcare fraud attracts criminals because the penalties are lower than those for other criminal offenses. There are low barriers to entry, schemes are easily replicated, and there is a perception of a low risk of detection. We need to alter the criminal's cost-benefit analysis by increasing the risk of swift detection and a certainty of punishment. As part of this strategy, law enforcement is accelerating our response to fraud schemes. The HHS-DOG Medicare Fraud Strike Force model described in my written testimony is a powerful anti-fraud tool and represents a tremendous return on investment. These strike forces have proven highly effective in prosecuting criminals, recovering payments for fraudulent claims, and preventing fraud through a powerful sentinel effect. In conclusion, our experiences and results in protecting HHS programs and beneficiaries have applicability to the current discussions on healthcare reform. We believe that our 5-principle strategy provides the framework to identify new ways to protect the integrity of the programs, meet the needs of beneficiaries, and keep federal healthcare programs solvent for future generations. We appreciate the opportunity to work with the committee and welcome your questions. Thank you.
Thank you. Thank you both. I'm going to ask my questions of Mr. Hackbarth, but not because what you said is not important, Mr. Levinson. I think this whole issue of enforcement and fraud and abuse is really crucial. But yesterday, Mr. Hackbarth, I asked basically the same question of Secretary Sebelius. In other words, you know, on the one hand, we're talking about reductions in payments for certain Medicare and Medicaid programs. On the other hand, we're talking about enhancements and, you know, actually spending more on other aspects of Medicare and Medicaid. For example, Medicare Part D, filling up the donut hole. And you do both. In other words, my understanding is that, you know, your recommendations, which many of which are incorporated in this discussion draft, accomplish both purposes. So what I wanted to do, though, is I think there's more media attention on cuts than there is on what you do to enhance programs. So I wanted you to talk a little bit about what motivates MedPAC to propose some of the reductions we're contemplating, like the Medicare Advantage, the home health rebasing, productivity into payment updates, and the rest. But why is it that MedPAC sees these as important policy proposals on their own terms, not because of, cost savings?
Mm-hmm. Well, Mr. Chairman, we believe that pressure on the prices in the Medicare payment system is important to force the system towards more efficiency. As you and the other members of the committee know, Medicare has administered price systems that are set through a government process as opposed to market prices. We believe that what we have to do with that administered price system is mimic, so far as possible, the sort of pressure that exists in a competitive marketplace. The taxpayers who finance the Medicare program face relentless pressure, often from international competition, for example, forcing the firms that they work for to lower their costs day in and day out. We think the healthcare system must experience the same sort of pressure.
And then the solvency of the trust fund is extended and premiums were reduced and the program is maintained for future generations. So that's the ultimate goal.
Absolutely.
And let me ask you another question about, we get this argument from some, and not too many, but some employers and providers complain about alleged cost shifting from Medicare to the private sector. The argument is something like if Medicare would pay more, private plans could pay less, and so healthcare would be cheaper for employers and others. I don't understand how increasing Medicare payment rates would lead a private hospital to decrease the prices it charges private insurers. And can you explain this to me? I know I'm asking you the opposite of what you believe, but what?
Yeah, well, let me start by saying that we believe that Medicare payment rates are adequate. We don't believe that they're too low. We don't believe that they should be increased. And let me focus on hospital services as an example of that. We look at the data in several different ways. We've looked at time series data, and you see there's a pretty consistent relationship. In periods where private payments are generous, Medicare margins become negative. And it's our belief that that's because when the private payments are generous, hospitals have more money to spend, and they spend it. It's a largely not-for-profit industry. If they get revenue, they will spend it. And then we see the same pattern when we look at individual hospitals. So what we've identified is a group of hospitals that don't have a lot of generous payment from private payers. They have constrained resources. Those institutions lower their costs and actually have a positive margin on Medicare business. They don't have the luxury of additional private money flowing into their institutions. They're forced to control costs, and they do control costs as a result.
And so you disagree with claims that Medicare is responsible for high health insurance premiums?
No. If institutions, clearly the rates paid by Medicare and private payers are different. Private payers pay higher rates. It does not follow from that, however, if you increase Medicare rates, that the private rates would fall.
Okay. Then let me just one more thing about access. We hear about in some parts of the country that, Medicare enrollees say that they can't find a doctor willing to accept new patients. Based on your research, do you have any reason to believe that we have a crisis of access in Medicare, that basically providers are not taking Medicare in a significant way?
Each year we do a careful study of access for Medicare beneficiaries, asking both patients and physicians. Our most recent patient survey, which was done in the fall of 2008, found that Medicare beneficiaries are more satisfied with their access to care than private patients, privately insured patients in the 50 to 64 age group. The one area of concern that we do have is around access to primary care services, especially for Medicare beneficiaries looking for a new physician, for example, because they've moved. That's the area where we see Medicare beneficiaries reporting the most problem. But we also see privately insured patients in the same circumstance reporting problems as well. So we don't think the issue is a function of Medicare payment rates, but rather too few primary care physicians.
Which was one of the things we're trying to address in this discussion draft. Thank you. Mr. Deal?
Mr. Hackbart, let me follow up on one of your comments about your look at those hospitals that have higher ratios of Medicare patients and lower ratios of private pay patients. And I believe your statement was that they are able to make a profit and in fact be more profitable than some of the ones who have lower volume of Medicare patients. Don't those hospitals receive dish payments as a general rule?
Some of them may, yeah.
Does your recommendation in any way address whether dish payments should continue or be abolished?
We have had some discussion, Mr. Deal, about refocusing dish payments. We have not recommended abolishing them.
Okay. Mr. Levinson, the draft talks about expanding Medicaid coverage and providing federal payment of 100% for some of this expansion of new populations so that the states don't have to pick up even their matching share in their Medicaid formula. If that is the case, if the federal government picks up 100% of this cost, are you concerned that states will no longer have the incentive to look for the waste and the fraud and the abuse because they don't really have any state dollars in that pot? Is that a concern from your standpoint?
Well, it is certainly always a concern about what is occurring with the federal share of Medicaid, and indeed, as we look for a larger share of that on the federal side, it becomes of greater interest to us at the federal level. It's an issue, actually, that I, as a member of the Recovery Act Accountability and Transparency Board, is already dealing with my colleagues on the board, because the ARA does include a significant increase in the federal share funding to alleviate states of some of the Medicaid burden. And in some of the states, particularly in the south central part of the United States, we are approaching a level where states give little, if any, contribution to Medicaid. So we are focusing on ensuring that there are controls in place to make sure that the Medicaid dollar is protected. But as the federal involvement becomes greater, the need for more federal monitoring of those dollars also becomes greater.
Because the states have been the primary enforcement, first line of enforcement against fraud and abuse with oversight from the federal. So you're saying that there may be a need for more federal oversight?
That is correct. Historically, the Medicaid fraud control units, which exist in nearly every state of the union, have been really the first protectors, as it is, of the Medicaid program. We have provided oversight. In the last several years, though, Congress has provided us additional funding to be more involved in the monitoring of those Medicaid dollars as the federal share has increased.
Mr. Hackbart, in your testimony, you make reference, I think, to the fact that about 60% of beneficiaries now buy supplemental policies to cover part of their Medicare cost. That seems to me a little bit inconsistent with your conclusion that the Medicare reimbursement rates are adequate. I know one is from the provider standpoint and the other being from the patient standpoint. Do you foresee from the patient standpoint that if we model everything after the Medicare reimbursement rates in the Medicare model, that there's going to be a need for even more purchasing of supplemental insurance by individual patients?
Well, as you say, Mr. Deal, there are two distinct issues. One is the adequacy of payment rates to providers, and we believe those payment rates are adequate. The Medicare benefit package is probably not designed the way any of us would design it if we were starting with a clean piece of paper. The design could be streamlined, and that process may reduce the need for beneficiaries to buy supplemental coverage. For example, if we were to add catastrophic coverage, a key missing component of Medicare, that might reduce the perceived need for supplemental coverage.
Okay.
And we've begun looking at that redesign issue.
Real quickly, you were going through your principles that you have recommended, and you got through most of them, I think. In the very short time that I have left, are there any of those principles that you are concerned that are not being addressed in this discussion draft, in particular, any that you have great concern about?
Off the top of my head, Mr. Deal, I can't think of one.
Okay. Thank you, Mr. Chairman.
The chair now recognizes Mr. Murphy for his questions.
Thank you very much, Madam Chair. And Mr. Hackbarth, thank you so much for all the work that you've done guiding this Congress on this issue of moving away from a volume-based system to a system that attempts to really reward outcome and performance. And I think I, for one, am worried that if we don't take advantage of this moment in time with this healthcare reform debate to make those changes, that we may never be able to make them. And so I know Mr. Deal just asked you a general question about whether there were points of reform that you've pushed that aren't in this bill, but I wanted to ask specifically on this issue of payment reform. Mm-hmm. Have you taken a look at this bill with regard to payment reform, and how do you think it measures up versus what you think could be potentially done through this Reform Act with regard to transforming our payment system?
Yeah. Well, as I indicated to Mr. Deal, I think that the bill's provisions on Medicare are pretty comprehensive and address the major issues that MedPAC has raised about the Medicare program. Having said that, some of the provisions, let me take an example, accountable care organizations or bundling. You know, the bill provides for pilots of these new ideas. And in fact, that's what MedPAC has recommended. These are complex ideas that will take time to develop and refine. So the bill includes provisions. We shouldn't assume from that, oh, it's a done deal. There's lots of work that needs to be done in CMS in particular to make these things a reality.
Well, and that was going to be my second question. You've had a lot of experience in pilot programs, right. And I think one of the things that some of us worry about is that that there has been a lot of research done on, for instance, the issue of accountable care organizations and bundling, and I think the majority of evidence is that they work, that they get good outcomes and they can reduce costs. And so if we are going to go into a bill that pilots these, how do we make sure that if the pilots turn up with the outcomes that pretty much every other, all other work on these payment reforms have done, how do we make sure that then that becomes a system-wide reform?
Yes, this is an issue that I think we discussed last time I was with the committee. The pace at which we make changes, reform the Medicare payment systems is way too slow. And one of the things that we've recommended is a broader use of pilots as opposed to demonstrations. And the difference in our mind is that under a pilot, the Secretary has the authority to move to implementation if the pilot achieves stated objectives. It doesn't have to come back through the legislative process. We think that's a very important step. And again, I'd emphasize CMS needs more resources to do these things both quickly and effectively. They're operating on a shoestring, and the work is too important, too complex to allow that to continue.
And let me ask then specifically about this issue of accountable care organizations. It seems to me that one of the ways that you expand out to a system of outcome-based performance is that you try to encourage physicians to join in and collaborate. Right. We've put an enormous amount of money in the stimulus bill into giving physicians and hospitals the information technology to create those interactions and that coordination. I guess I'd ask you, what are the ways that we need to be looking at in order to try to provide some real incentives for physicians to coordinate, become part of multi-specialty groups, enter into cooperative agreements. And then should we be looking at only incentives, or should we be looking at something tougher than incentives to try to move more quickly to a system by which physicians aren't operating in their own independent silos?
Yeah. Well, the fact that we have a fragmented delivery system, I believe, is the result of how we've paid for medical care, not just in Medicare, but also in private insurance programs for so many years. We basically enable this sort of siloed, independent practice without coordination. The most important step we can take is change the payment systems so that services are bundled together, and physicians of various specialties and various types of providers must work together. And there's abundant evidence that when they do that, we not only get lower costs, we get better quality.
Very much, Madam Chair.
Thank you. The chair now recognizes Congressman Burgess for his questions.
Thank you, Madam Chair. Mr. Akbar, it's always good to see you. And I have several questions that I'm going to submit in writing because time is so short during these Q&As. And I was going to reserve all my questions, in fact, for the Inspector General, but I just have to pick up on a point that was just expressed. And under the Accountable Care Organization, within Medicare, just within the Medicare system, with Medicare being an entirely federal system, it is not a state system, it is a federal system. So we don't have state mandates in Medicare. It functions across state lines. If we were to provide an incentive that is a backstop on liability under the Federal Tort Claims Act for doctors practicing within the Medicare system who practice under the guidelines of whatever we decide the Accountable Care Organization, the proper Accountable Care Organization should be, would that not be the type of incentive that we could offer to physicians that would not require increase in payments, but yet would bring doctors increase their interest in practicing within these accountable care organizations?
Yeah. Dr. Burgess, MedPAC has not looked specifically at the malpractice issue. We principally focus on federal issues. That's our
but if I could, we could make liability a federal issue within the Medicare system, because defensive medicine does cost the federal system additional dollars, as Dr. McClellan's great article from 1996 showed.
Right. And my point is that there's no MedPAC position on malpractice issues. As you know, though, I am formerly a CEO of a very large medical group, so I have a lot of experience working with physicians, and I know how large malpractice looms in the minds of physicians. Because they've not studied the issue in detail, I don't have a specific recommendation, but I think addressing physician concerns about malpractice is a reasonable thing to do. That's
well, one of the things that really bothers me about these discussions in this committee, you have so many people here who have never run a medical practice as you have, and as some of us have. Doctors tend to be very goal-directed individuals. That is why the fee-for-service system has worked for so long, because you tell us what to do and what the rules are, and we make a living at it. I'm not a big fan of bundling. I don't trust hospital administrators as a general rule, and I would not trust them to appropriately apportion out the payments, so not a big fan there. But there ought to be other ways to tap into the goal-directed nature of America's physicians to achieve the goals that you're trying to get. And right now, I don't think, at least from what I've seen, we're quite there. I'm going to actually go to Mr. Levinson, because what you have talked about is so terribly important. And let me just ask a question. Right now, within the discussion draft we're talking about, I don't think the numbers are filled in as far as the budget, the numbers, the dollar numbers that are going to be there. What do you need today in order to do your job more effectively?
Well, we certainly need the resources that we have been given by the Congress and by the executive, and it is certainly being used, I think, in an optimum way. But as the as the mission gets larger, the need for greater resources also is there.
And I'm going to interrupt you. That's an extremely important point because we've increased the FMAP and so in the stimulus bill and some of the other things that we're talking about doing. Is that not going to increase the burden, the pressure that's placed on you and your organization in order to provide the proper oversight?
Certainly our mission has been heading north for the last few years, and we are really pressed to enlist really the best investigators, evaluators, lawyers, and auditors we can find to handle a much larger budget than historically we ever have had before.
And it's not just you, because my understanding from talking to folks back home in the Dallas-Fort Worth area, from within the HHS Inspector General's shop and within the Department of Justice's jurisdiction, there's actually a deficit of prosecutorial assets, or actually assets have been had to use for other things, Homeland Security, narcotics trafficking, and there's not the prosecutors to devote to the cases that you all develop to bring those cases to trial.
That's a very important point, and sometimes it's overlooked how key it is to understand that the resources that are used to fight healthcare fraud really require a collaborative effort across several different government entities. And if you have the Justice Department personnel but don't have the IG personnel, right, and vice versa, you really have a significant problem. And
just one last point, I will submit several questions in writing on the issue that we're hearing so much about in McAllen, Texas, where the McAllen appears to be an outlier. Many physicians from the Texas border area were in town yesterday. I don't represent the border area, but they discussed it with me. They are concerned, obviously, about the negative press that they have been getting over the report by Dr. Gwande in the New Yorker magazine. Is there any special focus that you are putting on that area because of the possibility of diversion of Medicare, Medicaid dollars within other ancillary agencies, imaging, drugs, home health? Is the possibility that this number is skewed not because of practitioners in the area, but because, in fact, that we don't have the resources to devote to the investigation of the fraud, the prosecution of the fraud when it's uncovered?
Well, there are a number of high-profile areas that we oversee that we do need to concentrate on because they do tend to be areas where fraud, waste, and abuse tends to become a lot more serious than perhaps others. The durable medical equipment area, for example, especially in South Florida, has triggered our need to develop a strike force that's specifically devoted to trying to uncover and, to the extent possible, eliminate DME fraud in South Florida. We've had very good results there, actually, in being able to clean up many of the problem areas. I can point to other parts of the country where other kinds of issues have arisen that really require a concentrated effort by us, working with our law enforcement partners. I can't speak specifically to McAllen, Texas.
Is that on your radar screen to pull that into the investigative process?
I can only say that the entire nation is on our screen because we have such an extensive jurisdictional requirement.
All right. Thank you, Mr. Chairman.
The chair now recognizes Mr. Green for his questions.
Thank you. Mr. Hackworth, in your testimony, you cited a lack of care coordination and a lack of incentive of providers to actually coordinate care as a cost burden. And I agree, and we have several coordination bills pending before our committee. One is a Realigning Care Act, which focuses on geriatric care coordination. Your testimony cites geriatrics as an area in which care coordination is especially necessary. Can you elaborate on how geriatric care coordination can help lower health care costs? And again, we're dealing with Medicare, but maybe we could also deal with whatever we create in the national health care.
Yeah. Geriatricians, as you know, tend to focus on elderly patients who have very complex, multiple illnesses. And for those patients, not only is the potential for inappropriate, unnecessary care large, the risk to the patient of uncoordinated care is very large indeed. And so such patients really need somebody who's going to follow them at each step, not hand them off to specialists and then they're handed to another specialist, another. They need somebody as that home base to integrate and coordinate the services.
And I know that's our goal, is to talk about a medical home to where someone can do it. Any of us, a number of us had elderly parents who we've had to monitor the number of doctor's visits simply because they also take lots of different medications that there's nobody coordinating that except maybe a family member.
And the problem is, as you well know, Mr. Green, is that Medicare really doesn't pay for that activity outside of the patient visit. The phone calls that need to be made to pull together the services so that they're well integrated. So we made a series of recommendations to increase payment for primary care and the medical home, which in addition to the fee-based payments has a per patient sum to support that sort of activity.
And since we're also concerned about the scoring, did MedPAC look at, by creating this benefit of coordinated care, could we save on the back end? Is there something we could quantify, say, to CBO, or someone could say, we, over a period of time, we think we can save ultimately?
Yeah, well, it's our hope and perhaps even our expectation that there would be savings. But what we've recommended and what the Congress has done is a large-scale pilot so that, in fact, we can hopefully document those savings and to have a resulting CBO score from it.
Okay. And I know we have your, under current law, we have your Welcome to Medicare exam. Do you think that could fit in there with what we would call a geriatric assessment initially and then build on using that primary care?
Well, potentially, because it gives the physician, hopefully a strong primary care physician, an introductory assessment of all of the patient's problems right from the outset.
Okay. And again, I know there's a provision in the bill, and a lot of us have that interest, and that's one of the good things about this bill that we're dealing with. But again, since we're looking at scoring, say, you know, and it's hard to get CBO to say at the end we can save money. Not only save money, but almost much more humane dealing with Medicare or any patient, in all honesty.
What I can say, Mr. Green, is that, as I said in my opening comment, there is abundant evidence that systems that have strong primary care have lower costs and higher quality than systems that don't have strong primary care. You see that in international comparisons. You see that in studies within the United States that compare regions with one another. You see that within health systems. So there is lots of evidence of that sort. Whether CBO considers that strong enough to score is a CBO issue, not a med.
Maybe by your testimony we can encourage CBO to look at other countries that have a primary care emphasis and how that can reduce the cost. So maybe the bean counters can actually say this works. And so I appreciate your testimony, and hopefully we'll get that in our response when we get that score. So thank you. Madam Chairman, I yield back my time.
Congressman Gingrey is now recognized.
Madam Chairman, thank you, and I'm going to direct my questions to Mr. Hackbarth. Mr. Hackbarth, among the barriers to achieving value in Medicare cited in your testimony, you state that Medicare payment policies ought to, quote, ought to exert fiscal pressure on providers. Mm-hmm. You go on to state that in a fully competitive market, which I'm guessing infers that Medicare does not compete in a fully competitive market, that this fiscal pressure happens automatically in a fully competitive market. In the absence of such a competitive market, you suggest that Congress must exert this pressure by limiting payment updates to Medicare physician updates. When creating Medicare Part D, Congress considered instituting a set payment rate in lieu of creating a competitive market where competition among the pharmacy benefit plans might automatically keep the cost down. In the end, this Congress elected to go with that competitive model and forego payment rates set in statute similar to those that exist under current Medicare fee-for-service. The results, as we all now know, is that due to the private market pressure rather than government price setting, Part D premiums are much lower than anticipated and drug prices have gone down. So instead of exerting the fiscal pressure on providers that you suggest must be exerted due to the lack of a competitive market to do it automatically. I'm curious as to your thoughts on how using a competitive bidding process like what we did in Medicare Part D might achieve the same sort of efficiencies you suggest are required in traditional Medicare, but without having to resort to restricting the payments.
Mm-hmm. Well, let me approach it from two directions, Dr. Gingrey. If we look at private insurers in the private insurance marketplace, and we compare the costs of those programs with Medicare costs, what we see is that on average, and my evidence here is from the Medicare Advantage program, is that the bids submitted by the private plans are higher than Medicare's costs. They're not lower. Now, there are some plans that bid lower, but on average, the private bids are higher. So that's an opportunity for private plans to come in and compete and show that they can reduce costs, and by their own bids, they have not done that.
You're talking Medicare Advantage.
Medicare Advantage.
But of course, Ms. Hackworth, they do provide something that these three committees that have come up with this draft legislation, if you will, really want, and that is, of course, emphasis on things other than just episodic care, treatment of pain and suffering, but also wellness, prevention, and that sort of thing.
Yeah, some do, some don't. Yeah. The private plans are quite variable in their structure, how they deal with providers, what sort of care coordination programs they have, and most importantly, they're quite variable in their bottom line results. Some are outstanding, some are not.
Yeah. Let me go on to another question. I thank you for that response. One of the foundations of your testimony today is that the American healthcare system has serious quality problems. You quote, at the same time that Americans are not receiving enough of the recommended care, the care they are receiving may not be appropriate, end of quote. And then you go on to cite the Dartmouth Center for the Evaluative Clinical Services as proof of a wide variation in Medicare spending and rates of service use. Just to be clear, when you say the American system, Mr. Hackbarth, are you referring to the American Medicare system and not the entire American healthcare system? Am I correct in that assumption, given that the Dartmouth study used only Medicare data to support its findings? We're talking about the American Medicare system and not the entire healthcare system.
Well, in fact, the Dartmouth study is done using Medicare data because it's the most readily available, comprehensive database. I don't think there's any reason to believe that physicians are practicing different for Medicare patients and private patients. In fact, my own personal experience in working closely with physicians is that it's a matter of principle that they don't vary their care based on the insurance coverage of the patient. They treat the patient based on what the patient needs. Yeah. So I think it's a reasonable inference. If you see this variation in Medicare, you're likely to have the same variation.
Well, I know my time is up, Madam Chairman, but the reason I ask you this question, Mr. Hackbarth, because we're going to have another panel, probably several more panels today, but I think there are going to be some physicians that are practicing in the private market that might want to dispute what you just said. But thank you so much for your response, and I yield back, Madam Chairman.
Thank you. I now yield myself my time for questions, and I thank you both for your testimony today. Mr. Hackbarth, we're sort of picking on you, I think, but you can tell from the questions that Medicare payment reform seems to be a very pressing issue for many of us. And one of the Medicare payment reforms we're suggesting in this legislation is a change to the GYPSY formula in California so that it is now based on MSAs, the Metropolitan Statistical Area. 2 of the counties I represent in California are negatively impacted by the current payment formula. Mm-hmm. Physicians in both San Luis Obispo and Santa Barbara counties are paid less, much less, they would say, than the actual cost of practicing medicine. my question to you is in general, but also specifically toward California. Will the gypsy provisions improve the accuracy of payments in the new fee schedule areas that you, across the country, as you have envisioned them?
Yeah, the provision related to California in the bill is based on one of two options that MedPAC developed for CMS back in, I think it was 2007. So the approach in the bill is consistent with the advice that we've given CMS.
Excellent. And then maybe you could elaborate a little bit on the benefit, obviously, that you are seeing from having physician payment areas aligned with hospital payment areas. And is that, again, consistent around the nation once we get our alignment correct in California?
Well, the issue that we focused on was specific to California. As you know, the gypsies work differently in different states. And so our recommendation wasn't that this approach be applied everywhere, but we saw it as a reasonable solution to the California issues that you and other members have raised.
Now, we have seen that other areas of the country have this disparity as well, but do you think those are best resolved on a regional basis? Yeah,
different states have elected to resolve it differently, and we think the problems are not national in scope, but more isolated, and more tailored approaches are the best way to go.
And that would be a pattern that you might suggest in other areas as well, that we look at regional issues, particularly at least in the payment schedules?
Yeah, well, you know, that's a big statement, and I'd want
well, I'm just wanting to see how far you want to go.
Yeah, I'd like to take a look at, consider the issues one by one, as opposed to make that as a broad policy statement.
Well, I know my California colleagues, but this has been a real serious detriment to Medicare, in the practice of Medicare in our state. In many of the regions, that the cost of living has been very different from what the allotment has been. So this becomes for us a really vital component of Medicare reform under this bill.
And as I say, we think the approach in the bill is a reasonable one, and it's one of the options that we recommended to CMS.
Okay, I'm going to yield back my time. And recognize Mr. Bouyer for his questions.
See a company in Tampa just shut their doors to 500 jobs due to the S-chip bill. They're going to send the tobacco, those cigars to be made offshore. Just thought I'd let everybody know. Who really cares, I guess. This has been a challenge to get my arms around this in a short period of time, just to be very honest with you. So I'm trying to understand. I just went through that tobacco bill where the majority froze the market. So they love this talk about competition, and they love to freeze the market in place. And I'm getting a sense that that's what you're doing in this bill also. You freeze the market. So those of whom have existing plans, you freeze it, grandfather it, and then you got to figure out how you move people into the exchange. And if you, and when we freeze that market, so help me here with my logic. I'm trying to figure out what you're trying to do. We freeze that market, and you want to try to move a population into an exchange. You can grandfather so people can keep their existing coverage. But if at some point in time that employee chooses to move to a government plan, then the employer has to pay an 8% tax on it. Is that right?
Is that correct?
Yes.
Mr. Byer.
Pronounced Bouyer.
Yeah, Bouyer, I'm sorry.
Okay.
Our focus is on the Medicare provisions of the bill. And the bill is not our bill. We are advisory
Okay, so
body.
you can't answer that question.
Absolutely not. That's beyond our jurisdiction.
No, that's okay. Well, let me ask a question that is within your jurisdiction. You had, sir, you had suggested that encouraging the use of comparative effectiveness information would facilitate informed decisions by providers and patients about alternative services for diagnosing and treatment of most common clinical conditions. Is that correct?
Mm-hmm.
Means yes?
Yes, sir.
Thank you. Following your line of reasoning, could the Medicare program also use this research to exert fiscal pressure on drug and device makers or even restrict certain procedures based solely on price?
What MedPAC has recommended is that the federal government invest in comparative effectiveness research, make it available to physicians, patients, insurers, for them to make their own decisions about how to use the information.
Then how best do we, i.e. Congress, how best do we make sure that this research is used to inform the consumer and providers without being an excuse to exclude or ration certain types of care? How do we best do that?
Well, decisions about how Medicare would use the information are issues on which Congress can legislate. What MedPAC has recommended is investment in information to be used in a decentralized way by all of the participants in the system.
All right. Mr. Levinson, one of the great concerns I have is, would you be able to address a comparison or analogy on Medicaid? I know you're Medicare. You guys are claiming lanes of jurisdiction here.
Mr. Boyer, we actually, as an Office of Inspector General, we oversee all 300 programs of the department. So we also have important oversight of Medicaid.
All right, thank you. So most of the fraud cases with regard to Medicaid, are they discovered by the states or are they discovered by the federal government?
Medicaid cases can be developed along a very wide spectrum of possible sources.
I understand, but are most cases discovered in the states or by the federal government?
I would have to find out those numbers for you. I suspect it would be mostly states in terms of absolute number, but in terms of dollars, because some of the biggest.
All right, don't do it by dollars. You do it by cases.
By the number of cases.
I think common sense tells us. Let me jump ahead.
Given the Medicaid fraud control.
I think common sense is going to tell us that if states have a stake in the game, that they have an incentive then to make sure they go after fraud cases. If federal government picks that up at 100%, my concern is, are we disincentivizing states with its oversight responsibility, which places more on you? And is that a concern to you?
It is certainly a very important concern that we make sure that every Medicaid dollar, and we of course have responsibility for the federal share of that Medicaid, is accounted for as much as possible. And as the federal share, as the FMAP goes north, goes up, obviously our reach needs to be greater, our concern needs to be elevated on the Medicaid side. Absolutely.
Thank you. The gentleman from Iowa, Mr. Braley.
Thank you, Mr. Chairman. Mr. Levinson, to follow up on that point, all of us on this subcommittee are strongly opposed to fraud in any healthcare delivery system. So let's start with that premise. I think the real elephant in the room is that fraud is a small component of what the real obstacle is to meaningful healthcare reform, and that's waste. Because according to many reliable projections, there's $700 billion annually of waste in Medicare delivery, which is a much greater problem, because if you take that number and multiply it over the 10-year period of this healthcare bill we're talking about, you're talking about $7 trillion of cost savings that would more than pay for the entire cost of the program we're talking about. So isn't it waste that's really the problem here?
Mr. Braley, we try to identify and correct issues of fraud, waste, and abuse, and we do not have solid figures in which to share with you exactly how that pie may be divided specifically. But all of those kinds of issues are of great concern to the office, and we have work that supports recommendations in all of those areas.
And they should be of concern to American taxpayers also.
Absolutely.
Okay. Mr. Hackbarth, I really appreciate the effort that you and MedPAC have put into this. You mentioned the objectives of healthcare reform being high-quality care and protecting taxpayers from undue financial burdens. And getting back to my point that I just made, under the current healthcare delivery system and reimbursement model, we are wasting billions of dollars every year, aren't we?
It's our belief that, yeah, we can do better with less. And there's lots of research to support that.
Well, and one of the problems that my healthcare providers in Iowa have is that for years, they consistently rank in the top 5 in every objective quality measurement and at the very bottom of Medicare reimbursement. Isn't that a summary of what's wrong with our healthcare model today?
Well, my home state of Oregon is also one,
exactly
with you in Iowa. And so that's a type of evidence that we can do better for less in Medicare. You know, I think it's good for Iowa and good for Oregon that we've got low health care costs and high quality. Not only does it hold down Medicare expenditures, it's good for our beneficiaries. It holds down their out-of-pocket expenses, their Medigap premiums. So I don't want to increase Iowa and Oregon to be more like some of the high-cost states.
Exactly.
I want to bring the high-cost states down to Iowa and Oregon.
And isn't that the problem? Because under Medicare's proposed pay-for-performance system, the modeling is based upon improvements in efficiency. So if you're a state like Oregon and Iowa who's already delivering efficient, low-cost, high-quality health care, you get no incentive from a model of reimbursement that's based only on improvement. Isn't that true?
Well, as we move to new payment systems, move away from our siloed fee-for-service system to bundled payment systems or ACOs, one of the critical decisions that's going to have to be addressed is how to set those initial rates for these new types of payment systems. And in that is an opportunity to address some of these regional inequity issues that have come up in the program.
But if you're going to base a public health insurance option on a Medicare model that already has built-in inefficiencies and inequities in reimbursement, what reform hope does that give to this country?
Yeah. We need to change the Medicare model, independent of the public plan issue. For Medicare's own sake, for the taxpayers' sake, for the beneficiaries' sake, we have to change the Medicare model.
Well, and I'm glad you mentioned that because Congressman Ron Kind and I have introduced the Medicare Payment Improvement Act of 2009, H.R. 2844, that attempts to do just that by identifying clear, objective quality measurements that are highly recommended by a number of healthcare organizations that are looking to improve efficiencies and increase quality. It examines things like health outcomes and health status of the Medicare population, patient safety, patient satisfaction, hospital readmission rates, hospital emergency department utilization, hospital admissions for conditions, mortality related to health care, and other items determined by HHS. Isn't it true that until we move to some transformational type of healthcare reimbursement, we are ignoring the real cost opportunities to transform healthcare and provide expanded access to coverage?
Yes. We believe that we need to adjust payment to reflect the quality of care. That's one type of change. But we also believe that we need to move away from fragmented fee-for-service payment to paying for larger bundles, paying for populations of Medicare patients. The big difference between Iowa and the high-cost states is on the utilization of services. How many hospital days per thousand, how many referrals to specialists and the like. Iowa tends to be low on those things, and the high-cost states tend to be high on those things. If we move towards a payment system that advantages places with lower utilization, like Iowa, that will begin to address these regional inequity issues that you're focused on.
Thank you.
Thank you, Mr. Braley. Mr. Shimkus.
Thank you, Mr. Chairman, and I appreciate the little comments we had before my questioning. I'm going to follow up on something I addressed last night, and addressing just the basic FMAP formula, which has been a bone of contention for me for many, many years. I believe it's been flawed and does not accurately reflect a given state's need to meet its Medicaid obligations. So that's kind of where I'm coming from. The format does not accurately reflect the difference between a state's fiscal earnings, low-income citizens, or cost of delivery of service. This results in states like mine, and I think other states, if my colleagues would do some research, which only having a match of around 50%. We know in the testimony yesterday we had New Jersey here, we had California. They're also 50% match states, and I've got the list here where every state falls. But it falls short of its needs, yet other states have matches as high as 75%. Overall, the FMAP formula has resulted in the federal government's financing remaining around 57% across the board, yet the discussion draft seeks to have states enroll childless adults ages 19 to 64 up to 137% of poverty line and have the federal government finance 100% of this new Medicaid population. That was part of the discussion we were having offline. Do you think it's fair that we continue to have these inequities among states when it comes to FMAP, given we aren't meeting the needs of many states, especially those with low matches?
Mr. Shimkus, would you like me to respond to that question?
It's a question of both.
I would have to say that our office, not being a policy office, we don't actually establish the FMAP rates. We certainly audit those among our auditors, but we're not a program office. We oversee that. So I can't...
So as an auditing office, you wouldn't disagree with that analysis that I've given?
Well, actually, the rate is higher now in some of the states as a result of the American
yeah, and that's
Recovery
a good point.
Investment
Yeah,
Act.
that's true. But there's still percentage inequities. So you have a 75% state that's now up to 83%. You have a 50% state that's up to maybe 60%. But, of course, there's no assumption. I mean, depending upon what we do on a bill, there's no assumption that those amounts remain, because the stimulus bill was a short-term bill. And there's no certainty that that input of money will remain.
Mr. Shimkus, we work with the numbers that we're given as opposed to establishing the numbers ourselves.
Mr. Hackbarth?
Mr. Shimkus, we focus exclusively on Medicare issues, not Medicaid. That's our jurisdiction under the statute.
Okay, let me go with a few other questions just to put it, you know, our frustration with this process of rushing through and having a draft is we've got to ask these questions when we have to, and I want to get these out. Would it be appropriate in the context of health reform to address the inequity of FMAP by recalculating the FMAP to accurately reflect needs, or at the very least level the playing field for every state? Levinson, do you want to?
Mr. Shimkus, that's really beyond my charter.
Good, okay. Mr. Hackbarth, same answer? Yep. Okay, so what I'm trying to establish is this. Illinois is a 50-50 match state, which means that for every dollar spent on Medicaid, we will write a check to the state for 50 cents. Okay? There are states out there that for every dollar they spend on Medicaid, the federal government sends them 75 cents. If we're doing health care reform, and the premise of this bill is when we add people to Medicaid, 100% of that will be spent, but it still does not affect the basic fundamental inequity of the FMAP. So what states have to do is they have to game the system. They have to go to HHS. They have to pass additional tax incentives to get additional rebates. We have the tax increase on beds in hospitals that we pass. So they pass a tax, they remit the tax back to the federal government gives them the tax back to them plus some additional revenue. So I would encourage folks my colleagues to look at their FMAP percentage. And if we're going to move on streamlining health care and reimbursement, even as we increase the amount for the new Medicaid people we bring on, we really bring some clarity and equality across the state lands and FMAP. And Mr. Chairman, thank you for letting me go 13 seconds over, and I yield back my time.
Thank you. The gentlewoman from Florida, Ms. Castor.
Thank you, Mr. Chairman. Good morning.
Good morning.
Mr. Hackbarth, you state in your testimony that the payment system for Medicare Advantage plans needs reform. The Medicare Advantage program continues to be more costly than traditional Medicare health services. The Medicare Advantage government payments per enrollee are projected to be 114% of comparable fee-for-service spending in 2009. It's up from 2008. The high Medicare Advantage payments provide a signal to plans that the Medicare program is willing to pay more for the same services in Medicare Advantage than it does in traditional Medicare and fee-for-service. Our discussion draft tackles the overpayment issue, but what would happen if we did not do this?
Well, let me begin by saying that MedPAC very much supports giving Medicare beneficiaries the option to enroll in private plans. So we're enthusiastic about that. Our objections are to the current payment system, which, as you say, pays significantly more on average for private plans than it would cost traditional Medicare to pay for the same patients. If we were to lower the rate, one of the effects of that would be to send a market signal to private plans about what we want to buy as a Medicare program. And it will reward plans that take steps to be more efficient, more effective in the care that they provide. So long as we continue to pay more, the signal that we're sending is mimicking Medicare, traditional Medicare, just at a higher cost is okay with us. And so long as we send that signal, we'll get more of that. We've got to change the signal to get the market response that we desire.
And ultimately help us control costs across the board.
Absolutely. And control costs for the beneficiaries as well, because all beneficiaries, even those who aren't enrolled in private plans, are paying part of the additional costs for Medicare Advantage.
And I'm afraid these overpayments have created incentives for extensive unethical behavior by insurance companies. 3/4 of the states report marketing abuses in Medicare, and I have some firsthand experience with this talking to seniors at retirement centers in my hometown where insurance salesmen have come in, targeted seniors with dementia who were on traditional Medicare and signed them up for Medicare Advantage, sometimes under the guise of coming in and selling their Medicare Part D policies and then switching them out. And what happens is that senior who has a long-time relationship with their doctor, oftentimes they lose access to that doctor they had under traditional Medicare because their Medicare Advantage plan doesn't have the same doctor. There have been cases where cash incentives have been provided to insurance salesmen, and this shouldn't be. We shouldn't have these incentives for fraudulent behavior. I think it's gotten out of hand, and unfortunately, CMS has all but abdicated its oversight role. The Congress some years ago took the state's ability away, their ability to regulate and oversee these terrible marketing abuses. Now, our discussion draft, it makes some very subtle change and with enhanced penalties for Medicare Advantage and Part D marketing violations. But don't you think we need to go back to having as robust a strike force as we possibly can and give the states the ability, they're closer to the ground, the ability they had before to tackle the marketing abuses. The National Association of Insurance Commissioners supports such a move. Without it, unless we do this, we'll continue to have this huge regulatory gap. But what is your view?
Ms. Castor, we certainly work with the states to, as much as possible, protect the Medicare and the Medicaid programs. We have a very good collaborative relationship with our state auditors and state and local law enforcement. There are jurisdictional divides, and we try to respect those. but to the extent that we can actually understand schemes that are broader than just one particular matter, that really allows us to do our work more effectively, because the fact of the matter is although we are one of the larger Inspector General offices in government, given the size of our programs, we are very stretched. We only have a few hundred criminal investigators to handle, billions and billions of dollars stretched across the country in a variety of healthcare contexts. But I certainly would underscore the importance of being able to work very much hand in glove with our state and local partners.
Thank you. Gentleman from Pennsylvania, Mr. Murphy.
Thank you, Mr. Chairman. I thank the panelists for being here. Some questions about Medicare. It was founded in 1965. In the ensuing years, has there ever been a time when any president or any Congress has really gone back and overhauled the program, and this program being established back in pre-CT scan and MRI days? Has there ever been a comprehensive overhaul of the system to modernize it, reform it, make it work more effectively?
Well, the payment systems have changed. Medicare began with payment systems that were based on cost reimbursement.
But in terms of how it functions, because today you're talking about a number of interesting reforms, and has that ever been attempted before?
Well, the payment systems have been reformed. They have changed substantially over the life of the program.
But I mean,
we think more changes are warranted.
You're talking about the other delivery, like care coordination and preventing readmissions and things like that. That's never been attempted, right? I mean, in terms of overall reforms in the system.
There has not been payment reforms focused on readmissions, no.
Okay, I'm assuming you're talking about more than just payment reforms today, because your report has a lot more than just how the money gets spent. Okay. And in that, I mean, I noted in the 110th Congress, there was 452 bills put in by members of Congress to make some reforms to Medicare and Medicaid. I think 12 passed. And some 13,000 co-sponsors of these bills came through with members of Congress. So I look upon this that members of Congress themselves recognize there needs to be some changes in Medicare and Medicaid, but it seems to come slow. I'm wondering, in this process where some of the changes you recommend here, and I applaud them because of things I've been asking for a long time too, care coordination. I mean, we'll pay to amputate the legs of a diabetic, won't pay to have some nurse call them with these cases. We recognize 1 in 5 chronic illnesses gets readmitted to the hospital. We haven't been working at keeping them out. And those are major changes to make here. Mm-hmm. My concern is the speed at which the federal government moves to make changes, number one. And two, does the federal government have to run its own insurance plan, given its track record of not being very good at coming up with timely changes? Can we come up with some of these changes with the federal government pushing for and mandating some of these changes within the private market, mm-hmm. And in the meantime, Medicare pushing some within itself? Is that possible to do that?
Well, I think we need to do some of each. The potential for Medicare Advantage is to invite private plans to enroll Medicare beneficiaries, do things differently to get better results for both the beneficiaries and the program. Because of the way Medicare Advantage works, the way the prices are set, it has not fulfilled that potential. It's allowed private plans to enroll Medicare beneficiaries, essentially mimic traditional Medicare with all the same problems. So one of the reasons we believe Medicare Advantage reform is so important is to reward private plans that do it better.
Okay, so so in other words, they can't just continue on with business as usual, but Medicare Advantage, they should really be using these things for what it was designed to be, and that is really work at prevention, really working at care coordination. Am I correct on that? Okay. There's something else mentioned here. A point was made earlier, encouraging use of comparative effectiveness information and public reporting and provider quality, et cetera. This also relates to the issue of evidence-based medicine and evidence-based treatments that many people refer to. Throughout medicine, there's many branches that have their own standards and protocols. The College of Surgeons, American Academy of Pediatrics. Would those be things that Congress or the FDA or HHS could look towards in terms of what these standards might be, in terms of what is the best practices and what would be the standards and protocols to use?
Well, specialties are quite variable in how they develop those standards, those protocols. So it's difficult to generalize about them. Let me focus on the area of imaging as one example. We had as a witness before MedPAC, the president of the College of Cardiology, to talk about imaging issues. And one of the things that she called for was more information so they can move from just consensus-based guidelines to evidence-based guidelines. The potential and comparative effectiveness research is that we give physicians and societies the raw material to do a better job at what they want to do.
So, and this is a critically important point, and one that we should not rush at because it's going to have long-term implications. So the college cardiologists or radiologists or whatever that is, we have to make sure it isn't just they've all sat down and voted that this is what the best thing. But there really needs to be a demand, and this is where a valuable role government can have, the HHS or FDA, to have oversight to say we want to see evidence-based medicine here. Is that what you're suggesting?
That's the goal. We need information for physicians as well as patients to guide that.
I mean, this is a critical thing, Mr. Chairman, and one I hope we continue dialogue on because it's going to be a factor that I think makes or breaks some of the budget is how we go through there. And I think also deal with the issue of who's making the decisions, and I think a valuable place where this committee can have tremendous oversight in working with medicine. And with that, I yield back. Thank you, sir.
Thank you, Mr. Murphy. Gentlewoman from Wisconsin, Ms. Baldwin.
Thank you, Mr. Chairman. Mr. Hackbarth, welcome back to the subcommittee. I recall when you were here in March, we had quite a dialogue about, as we have today, about the difference between pilot projects and demonstration projects. And you expressed then, as you have here today, some hesitation about the administrative and regulatory burdens associated with demonstration projects and how that affects the ability to scale those up if they've proven successful. This draft healthcare reform legislation offers new pilot projects in accountable care organizations and medical home models. And I'm wondering if it's your sense that these pilots will provide us, the Congress, and MedPAC with sufficient evidence to make broader payment reforms. And also, if you've examined these provisions in the draft, if you have any recommendations for further improvement.
Well, on the issue of pilots, we welcome the fact that the committee is looking at pilots. And what MedPAC has advocated, and we've talked about this before, is that Congress give the Secretary discretion to test a new payment method and to implement it if the pilot is successful. Establish goals in advance and then give the Secretary discretion, plus the resources necessary. And an important part of this, I think, is a much larger budget for the department to not just test ideas that come through the Congress, but to generate new ideas independently in the department. Right now, the demonstration budget's way too small for that.
In MedPAC's most recent reports, there's an interesting sidebar concerning the physician group practice demonstration, which serves really as a foundation for the accountable care organization pilot in the draft bill that we're looking at. You noted that a surprising number of the sites for the physician group practice demonstration project had high cost growth, and it's linked to the risk profiles of the patients at those sites. And it strikes me that basically there's an inference that these demonstration sites may be picking up more of their patients' medical issues, resulting in more treatments and increasing costs. What lessons do you suggest that we take from this demonstration?
Well, in setting payment rates for new payment systems like ACO, the details are very important in how the targets are set, how the potential gains are shared between the providers in the Medicare program, and how you adjust for things like risk, the risk profile of the patients. And so there are important steps that have to be taken from endorsement of a broad concept like ACOs to making it an operational, effective idea. And this is part of why we think the Secretary needs some flexibility and discretion in design and the resources to be able to do that quickly and effectively. On an idea like ACOs, we're unlikely to get it exactly right the first time. And so there needs to be ongoing cycles of refinement and improvement that requires discretion and resources.
And we can certainly relate to the difficulty to create a national program to rein in Medicare spending. And on the ACOs, the idea is to set spending targets to hold the providers accountable to the targets. If you tied spending targets to national averages, I guess I'd like to ask how are we going to attain or incent participation in higher cost areas, and do you have any ideas of how we would address that challenge?
Yeah, well, this goes back to the dialogue I had with Mr. Braley. One of the very important details in these new payment systems like ACOs is how you set those targets. If you take a group that has a very low historic level of utilization, they've been very efficient, very high quality, and say, okay, we're going to set your target at your historic level of costs, it's going to be more difficult for them to beat that and earn rewards than for a practice that's in a very high cost state and performing very poorly. That's not an equitable way to get to where we want to go. So setting that target rate so that you reward historic performance as well as future performance is, for me, a goal in the target setting. Now, in order to do that, you're going to have to squeeze someplace else. You're going to have to squeeze those high-cost places to offset the costs. So, again, the details in this are very, very important, and the Secretary needs to be given the latitude to strike that balance.
Thank you. Mr. Pitts is next.
Thank you, Mr. Chairman. Mr. Levinson, in your testimony, you mentioned Medicaid-specific services that are services unique to Medicaid that could lead to significant savings. And one example you cite is school-based health services. You say that OIG, quote, consistently found that schools had not adequately supported their Medicaid claims for school-based health services and identified almost $1 billion in improper Medicaid payments, end quote. Can you go into this further?
Mr. Pitts, we do make audit recommendations to the Centers for Medicare and Medicaid Services based on our audit findings as our auditors look at programs that are supported by the program. And that is an area that the OIG has identified over the last few years as one that CMS needs to focus on more clearly to make sure that those dollars are really spent appropriately.
Well, what were some examples of these improper payments? What was Medicaid paying for?
Well, overall, they were paying for those kinds of services that are not included in the program, but I would need to provide more detail to you as a follow-up to our hearing.
Now, the Bush administration proposed regulations which would stop these fraudulent services and stop wasting taxpayer dollars. However, the present administration has put a moratorium on these regulations. Do you believe that this moratorium should be lifted?
We do not comment on what the executive branch decides to do with those kinds of regulations or not. We certainly, advance what we believe would be appropriate ways of being able to account for the Medicare dollars better. And our recommendations are given in the first instance in these kinds of cases to the Centers for Medicare and Medicaid Services.
Do you have any idea how much money in total might have been wasted in this way?
Our audit findings will indicate the dollars that we believe are not appropriately spent under the Medicare program, and I don't have that dollar figure immediately at my fingertips. We'll certainly provide as much detail as we can based on the audit findings we already have.
All right. In your testimony, you mentioned the creation of the Healthcare Fraud Prevention and Enforcement Action Team. Can you give me some examples of what cases this team is currently addressing?
Well, the most recent example would be the case that was publicized yesterday in Detroit, a Medicare infusion drug fraud case that has resulted in 53 indictments. There have been 40 arrests so far. 40 of our agents have been involved in what is claimed as $50 million in false claims. This is a strike team in which we're working with the FBI and local law enforcement to clean up a significant Medicare infusion drug problem that now infects the city of Detroit. Some of these issues have actually migrated from South Florida. So the strike force effort is to try to provide both national and regional focus on those kinds of frauds that that not only tend to plague particular cities in the country, but that also have regional impact. We already have strike forces in operation in a number of cities, but the effort now will be to extend that to more cities over the course of the next year.
Mr. Chairman, I don't know.
You want the time? The time? You have a minute left.
1 minute left?
Yeah. I'm sorry.
How do you get the provider ID number? The criminals get the provider ID numbers?
Well, obviously through a variety of fraudulent means, but it's too easy at this point in our system to get provider numbers, and that has been a constant theme of our office over the years, that enrollment standards have not been sufficiently rigorous to ensure that we're not allowing, in effect, criminals to masquerade as healthcare providers. Mm-hmm. And that has been a significant problem, not just in Detroit and Miami, but really throughout the country. And one of the key principles we have in terms of our anti-fraud fighting effort is to make more rigorous who actually gets in the program, because historically there's been too much of a right to access as opposed to the privilege of actually being enrolled in the program.
Mr. Boyer wants to follow up.
I guess we want to be responsive here. How are they relying on insiders within the system to get these ID numbers, or you don't want to tell us so that others will know how to? I mean, you can tell us offline.
Mr. Boyer, let him answer the question, but the time has expired. I have to apologize. The electronics have gone off again, so I'm going to just have to tell everybody when their 5 minutes is up. But go ahead and answer your question.
Thank you. I think it probably would be better to have an offline conversation, because the schemes are varied and some of them are rather sophisticated, and it's probably better not to discuss in any detail what actually occurs in a public hearing.
Thank you, Mr. Chairman.
Thank you. Next is Ms. Eshu, and I'll just tell you when the 5 minutes are up.
Thank you, Mr. Chairman. Gentlemen, thank you for your testimony today, and to the chairman for this series of hearings with many, many panels this week. As we look to reshape America's healthcare system, we have very clear goals that we have set down. We want it to be universal. It needs to be affordable. We think that choice is important. We believe that many of the rules that need to be rewritten, that the insurers, the private insurers employ amongst them, knocking people out because they have pre-existing conditions and gender-based issues, et cetera, et cetera. So that's on the kind of on the one side of the ledger. The other side of the ledger, in my view, are two major issues. One, that we be able to achieve this without raising taxes. And number two, maybe I should have said number one, that we reform Medicare and strengthen it. We've read the report of the trustees. We know that they shaved off 2 years, and that we've got until 2017. 2017, believe it or not, is not that, it sounds like it's another century away. It's a handful of years away. So my question to both of you is, what are the large ticket items that you can name today for us that will strengthen Medicare? Mr. Levinson, I recall a hearing here many, many years ago on waste, fraud, and abuse, and what essentially the private sector ripping off the public sector. And you've touched on that today. In fact, we had testimony from someone whose case had been adjudicated, and he was on his way to prison. And he came here and explained how he had ripped Medicare off. And it was essentially the private sector ripping off the public sector. So what are the price tags that you can tell us about in these efforts that will save us money, save Medicare money, and overall strengthen Medicare as we come through this large effort, this overall effort to reform our nation's health care system? Because I believe if we don't reform and strengthen Medicare, that we will not have accomplished what needs to be accomplished.
Let me go first. I would name 4 things. One is that we need to continue to apply pressure under the existing payment systems in Medicare.
Can you speak a little louder, please? Can you speak just a little louder?
We need to continue to apply pressure to the update factors in the existing payment systems.
And what is that going to? What do you think that's going to save us?
Well, it depends on exactly what the levels are, but it's
Has MedPAC done that work?
Well, the CBO does the estimates of the budget impact of different recommendations.
Do you have any idea what that might be?
Again, it depends on the specific level, but tens of billions or more over a 10-year horizon. A second area that I mentioned is Medicare Advantage. There, as I think you know, the CBO estimate is higher than $150 billion over 10 years. A third area that I'd mention is readmissions, excess readmissions. And off the top of my head, I don't know what the estimate is for that, but there was a proposal in President Obama's budget on that, and it's a fairly significant number. Then the fourth area that I'd emphasize is shoring up primary care. Now, that doesn't lead to direct savings, but I mention it here because if we allow things to go as they are right now, our primary care base is going to continue to erode away.
You spoke to that earlier, so I appreciate that.
That'll cost us big money.
Mr. Levinson?
Yes, Ms. Eshoo.
And thank you for your wonderful work as IG. We really can't function well and do oversight without the IGs, and I just think that you all should be canonized. So,
well, on behalf of 1,600,
be interesting to have a Levinson canonized, right? Yeah. I'm pretty ecumenical, though. So.
Well, it so happens that, of course, Dante was talking about fraud 700 years ago.
Right.
So it's an issue that is both timely and has a long and very troublesome pedigree. But on behalf of 1,600 very dedicated auditors and evaluators, investigators, and lawyers, thank you so much. In just one, as I look at some of the recommendations that are in our compendium of unimplemented recommendations, our auditors estimate that we could, the program could save $3.2 billion over 5 years if we just limited the rental time for oxygen equipment. I mean, I think that there are specific areas where there are significant savings that can be had. As I look at just our most recent semi-annual report, in terms of monies returned to the Treasury, we're expecting just in the first 6 months of the fiscal year, $275 million in audit receivables and $2.2 billion in investigative receivables. A lot of that has to do with pharmaceutical cases. Pharmaceutical pricing, of course, is a very significant area that can also, if properly addressed, can save significant dollars. It would be hard to come up with total figures on a list of top 10, but certainly pharmaceuticals, DME, getting the dish payments right. We think that it is important to clarify exactly what Medicare should be paying for the Medicare and the Medicaid dish payments and how the states handle those dollars. We need to avoid gaming the federal dollar so that it's clear, it's transparent about who is actually paying for what and how the states account for the dollars that come from Washington. I would hesitate to put a dollar savings on it, but I think that there is a great need for much more significant transparency and accountability in our programs, and that is a very helpful trend from the standpoint of our office.
Do I have any time left, Mr. Chairman?
No, I'm trying not to
Okay. Thank you
interrupt
very
it
much.
now.
Thank you.
Sure. Next is gentlewoman from Illinois, Ms. Schakowsky. I'm going to just tell everybody when the 5 minutes are up, just so you know. Thanks.
Mr. Levinson, one of the biggest single expenditures out of Medicaid is for long-term nursing home care. And I've been working with Chairman Waxman and Chairman Stark on a nursing home quality and transparency legislation, which has been included in the draft bill. And I'd like to know what you have found in terms of problems with nursing homes that would necessitate more transparency and oversight of them.
Yes, Congresswoman, it's been difficult actually to find out who makes the decisions when we investigate substandard care in nursing homes and try to locate exactly who financially is in charge. So I think the effort to create greater transparency in terms of ownership, in terms of management, and get a clear understanding of actually who is in charge would help our investigators and lawyers significantly in being able to both investigate and resolve some of the very serious quality of care cases that have emerged in the nursing home area.
We're going to hear some testimony a bit later that disparages the notion that there is any substantial fraud or wasteful spending on the part of some doctors that participate in the Medicare program. Would you agree with that assessment?
Well, I can only point to individual cases that we've actually worked on. We try not to generalize. Our investigators and auditors are very focused, very anchored on particular instances when it comes to either individual venues or a larger corporate structure. And we do have an existing and unfortunately a growing caseload. Workload.
Let me ask this though. Would you say that some may be fraudulent, some may be wasteful, but that in general, the decisions about utilization are provider-driven, as opposed to the kind of fraud or wasteful spending that's generated by individuals in the program?
You know, I would hesitate again to make any kind of generalizations because these individual cases are very much focused on the facts as we find them. But there are certainly cases in which we have found that we are frustrated in our ability to actually understand who makes the decisions in the nursing home chain.
Let me ask Mr. Hackbarth about the Medicare Advantage plans. It's great that in the Medicare program, consumers can actually go online and find out what Medicare pays for health care services. To your knowledge, is there a place where consumers can actually access rates that Medicare Advantage plans pay providers or other private insurers?
The actual payment rates for providers, not to my knowledge. I think most private plans consider that information proprietary business information.
In your view, will Medicare Advantage plans remain in the market if we eliminate overpayments?
I believe that they will, many will. Some will leave the market because they have a model that can't compete with traditional Medicare. But as I said earlier, we'd be sending an important market signal about the type of plan we want to participate. We want plans that can help us improve the efficiency of the system, not plans that just add more cost to the system. And when you send that signal, I believe in the market. I believe that we'll get more plans that can compete effectively with traditional Medicare.
What mechanisms will we need to ensure that Medicare Advantage plans and private insurers in the exchange meet a minimum loss requirement, a minimum loss ratio requirement?
Yeah. The minimum loss ratio, I think, it's a tricky issue. As you may know, I used to work for Harvard Community Health Plan, Harvard Pilgrim Healthcare, two very well-regarded HMOs. And this was a big issue for us sometimes with employers, how you calculate loss ratios. Our piece of the organization, the one I ran, is an integrated prepaid group practice. And we have a lot of clinical programs that we believe improve patient care that sometimes employers wanted to characterize not as medical care, but administrative cost. So that works against you in terms of calculating the loss ratio. So the details of this can be pretty tricky in my personal experience. So I'm always a little uneasy about just having simple rules on loss ratios. How you define those loss ratios is very, very important.
Thank you.
The time has expired. I'm sorry. Thank you. And next is the gentleman from Maryland, Mr. Sarbanes.
Thank you, Mr. Chairman. Thank you all. I got a couple of quick questions at the outset. Mr. Levinson, you talked about trying to step up efforts to curb some of the fraud. In particular, you talked about, in response to one question, the application process for new provider numbers and having that vet properly. Have resources been an issue in terms of the capacity of those people that do the processing and the review? Has the resource in terms of the number of folks that can do that been an issue or not an issue?
Well, that's an important question, Mr. Sarbanes, that in the first instance I think needs to be addressed and responded to by CMS, which is the agency that runs the program. And as an office that looks to see where the vulnerabilities, where the weaknesses are in the administration of a program, we have identified for some years now that enrollment standards are too lax, especially in specific areas of vulnerability like DME. And whether or not there are resource issues, we find too many of the wrong kinds of people are getting into the program. And therefore, we have recommended over the course of the last few years that enrollment standards be strengthened.
Well, I'd imagine, I mean, I used to do some of that work, and I would imagine that the best way to vet it on the front end is with a little more intensity of resources applied to actually going out and finding out who's behind these applications that are being filed. Let me shift gears. I was really intrigued by the discussion on the school-based health centers and some of the findings of fraud. In that discussion, there was an allusion to the possibility that that there was services being, that reimbursement was being sought for services that were not actually provided, but possibly there were other services being provided that one might view as important services. They just aren't services that Medicare or Medicaid reimburses. And I wanted to ask the question of whether this phenomenon, and this is, in my view, the problem, is whether you're talking about fee-for-service or you're talking about capitation. Either one of those can work okay if you're paying for quality as opposed to paying for quantity, and if you're paying for the right things as opposed to not paying for the right things. But maybe both of you could comment on whether the potential for fraud is greater when you have a system that pays for quantity versus quality, or is paying for the wrong things. And while I don't want to excuse fraud, if somebody is trying to find some payment for what they view as a very important service that is not covered under Medicare or Medicaid, that's a different kind of impulse than seeking to get paid for a service that's not being provided at all. And it seems to me the way the system is structured right now, and it is so distorted, that it leads to that kind of thing, because people say, this service is valuable, but Medicare won't pay me for it. And if we can move in a direction where we're paying smarter for things that make a difference, we might actually make some progress on this fraud issue. So maybe you could each respond.
Well, I do think the facts that you've laid out, Mr. Sarbanes, are important ones to focus on. The notion that there can be monies spent that are just not appropriately covered by the program. And in many instances, we're really not talking about fraud in terms of the legal definition of fraud. We're talking, though, about dollars that Congress, that the program says should be directed in a particular way, and our audit people, not our criminal investigators, find have not been spent appropriately, and then we make the appropriate findings and recommendations to CMS. Not all of our recommendations are acted upon by CMS. There unquestionably are judgments. Perhaps some of the kinds of judgments you're talking about here are judgments that programmatically are made by CMS over the course of looking at our recommendations, because just by the fact that we make those recommendations doesn't necessarily mean that the dollars will actually be collected. And I do think that it is important to distinguish between those who have an intent to take advantage of the program and those who unfortunately are simply not paying appropriate attention to our rules. But of course, given the precious resources, we take the rules as set by Congress and the Department seriously, and we report accordingly.
And the time has expired, I'm sorry. Next is Ms. Daggett.
Thank you very much, Mr. Chairman, and thanks to this committee. I know you've discussed some of the issues in general that I want to talk about, but I'd like to hone in on them a little more. My first question is you talked about, actually, Mr. Hackbarth, the MedPAC has talked about changing the Medicare payment system incentives by basing a portion of provider payment on quality of care. And to do this, Congress could establish a quality incentive payment policy for physicians and other plans, Medicare Advantage plans, healthcare facilities. I'm wondering if you have some specific recommendations you can make as to what kind of quality measures people would have to include to be, or to develop to be included in a quality incentive payment policy.
Well, let me focus on a few different areas of the program. For example, in the Medicare Advantage program, we've long advocated that a piece of the payment be adjusted to reflect the quality. And there are
But how do you do that?
There are well-established industry measures developed by NCQA that private employers use to assess health plans. We believe Medicare should be doing the same and adjusting payment accordingly. In the case of dialysis services, again, there's a pretty strong consensus about what the critical quality measures are. We've advocated that the dialysis payments be adjusted to reflect those outcomes for patients. Likewise, in hospitals, we think there are some strong consensus measures. In fact, Medicare requires, as you know, specific measures be reported. We'd like to see payment linked to that.
Do you think that the current, and I do know that because my heroine, Patty Gabot from Denver Health, is here on the next panel, but do you think that we could, do you think that this quality measures that we have in place now are sufficient as we move forward with comprehensive health care plan? Do we need some kind of additional mechanism?
Yeah.
Do we need additional quality measures? What do we need
Yeah,
to do?
I think the measures need to evolve over time. I think we've got starter sets, if you will, for a lot of providers, but we need to invest in developing them in the long term.
And who should do that?
Well, Congress has invested some money now in NQF, the National Quality Forum, which I think is a wise investment to build infrastructure for ongoing improvement in quality measures.
And do you think some of these quality measures that you talk about for Medicare Advantage can also be used for physicians and other types of health care facilities like hospitals and community health facilities?
Well, each provider group presents its own challenges and will require unique measures. I mentioned 3 areas: Medicare Advantage, ESRD, and hospitals, where I think there's a pretty strong consensus on starter set of measures. Other areas are more challenging. Physicians are more challenging just because of the nature of medical practice. You often have small groups or even solo physicians, so not a lot of numbers to do measurement.
But you know what, though, people like Geisinger and Kaiser and others have been able to develop quality measures for doctors that it would seem to me you could develop. And if you don't develop those for physicians, then it's hard to see how you can get the improvement in medical care at the same time that you get the cost containment in our system.
And I agree with that we do have initial measures. They're not comprehensive measures for physicians. They tend to be very focused process measures.
Right.
I think we can do a better job in assessing physician performance as we move to bundled payment systems where we get groups of physicians working together. We can start to measure outcomes, not just
That was my next question. To develop those measures, again, what kind of mechanism do you think, would it be the same one you talked about, that Congress, there's a group of us,
yeah.
Senator Whitehouse and myself and others who are very concerned that if we don't develop quality measures throughout the system, that we're really not going to have improvements in patient outcomes.
So we need a process for forging consensus and establishing a set of measures.
Right.
You don't want 12 different ones.
Right.
And everybody using different measures.
Right.
That's a burden on providers.
Right.
And NQF can be that process. It can grow into that process where we have consensus. Then we also have to invest in the research about what works. That's where comparative effectiveness comes in. That can provide raw material for specialty societies and the like to develop guidelines on what constitutes good care. And that can also feed ultimately into the assessment process.
Great. Thank you. Thank you, Mr. Chairman.
Thank you. Gentleman from Texas, Mr. Gonzalez.
Thank you very much, Mr. Chairman. This will go to the chairman. There are 2 major components of what we're considering, and the experience gleaned from Medicare is going to be used either by the proponents or the opponents. Just again, it'll be the performance of Medicare in the eye of the beholder. One is the public option, the other is the health insurance exchange. So I'm going to pose a couple of questions and then just let you respond, and that way it'll be the chairman that will be advising you that my 5 minutes are over. But first, I haven't met with a group of doctors in San Antonio yet that have agreed with the compensation adequacy. And what they're all saying is that you guys are basically working with stale data and information, that it's at least 2 years behind the times of what modern medicine and its practice entails. That's the first question, and I know that we've touched on it more or less, but that is going to be very, very important as we go out there with a broader plan that, again, has something that will mimic what we've been doing under Medicare. So that's the first complaint that we get. My colleague, Mr. Gett, also touched on something, and that was, how do you establish proper protocols? What is acceptable, best practices and standards? On the Small Business Committee, we had Governor Pawlenty, who came up, and I asked him that because my doctors asked the same thing. Different patient populations may dictate different practices and such. Well, Governor Pawlenty told me, he says, we got Mayo, they established the standards pretty much, and no one's going to argue with them. The question to you is, how do we ever really achieve nationwide standards that may address diverse populations and such? The last question is a somewhat interesting one because it presents a real dilemma for me back home. Texas has probably the greatest number of specialty hospitals. The question really is how is modern medicine being delivered in this country and to keep up with that. There are portions of this bill that would discourage, of course, specialty hospitals. Yet we are looking at what we refer to as bundling, and that is more centralization, more coordination, medical home, all that entails. But in essence, isn't that what specialty hospitals and many of these specialty practices provide? And that is, when a patient goes into those settings, that there are many different services that are being provided within that environment that otherwise would be separated out to different locales, offices, and other doctors. And we even have different specialists that argue among themselves as to what extent they should be able to do that. And I would just like your views on those 3 points. And again, thank you for your service.
Okay. That's a lot of ground to cover in just a minute or two. Starting with the stale data, I imagine what your physician constituents are referring to as Medicare claims data, which in fact is a couple years old by the time it's used in the policy process. That is a problem. That's an area where I think some wise investments in Medicare infrastructure would pay dividends. I'm not sure, however, that the age of the data would alter any of the recommendations we're talking about for reforming the payment system. With regard to standard setting, I do believe it's very important to have a process that is coherent and credible from the perspective of providers. I fear that sometimes we have an embarrassment of riches. We have a lot of different people saying this is what constitutes quality of care. Some of it's well-founded in research. Other pieces of it are not. If we want to send clear, consistent signals to providers, not just from Medicare, but from private insurers as well, we need to have a coherent standard-setting process. As I said a minute ago, Congress, I think wisely, has invested some money in NQF to start building that infrastructure. On the last issue of specialty hospitals, roughly 2 years ago now, MedPAC, at Congress's request, invested a lot of effort in analyzing specialty hospitals. Our basic findings were that when physician-owned specialty hospitals entered a market, costs tended to increase, not decrease. More procedures were done. The evidence on the quality of care there was not definitive evidence one way or the other that was better or worse. It seemed to be about the same. At the time we did our analysis, our big concern, our immediate concern, was that at least some physician-owned specialty hospitals were exploiting flaws in the Medicare payment system. They were focused on procedures where the Medicare rates were too high. We made recommendations, which Congress adopted and CMS has now largely implemented, to change payment rates so there aren't those gaping opportunities to exploit the system.
Thank you. Mr. Matheson is next.
Thank you, Mr. Chairman. I'm sorry I was not able to be here for all your testimony, but I do appreciate your coming before the committee today. The question I wanted to raise is, MedPAC has had the opportunity to make a lot of recommendations about how we can achieve greater efficiencies or greater value or good practices. And often, in terms when it comes to implementation, Congress has not necessarily followed through on that. Do you have suggestions for if there'd be a better structure to help assist in allowing these recommendations to be implemented in a more effective way?
Well, you know, one of my themes this morning has been that I think the Secretary of Health and Human Services and CMS need both more discretion and more resources. So they need the flexibility to refine, change payment systems over time to achieve goals established by the Congress. For every small change to have to come back through the legislative process is a very cumbersome process, and it makes progress very slow. And I'm not sure that's a luxury we can afford at this point. So more discretion and more resources for the department would be my first recommendation.
Do you have, in terms of making that recommendation, is there a specific proposal about what the resource needs might be, or is that something that we can look to maybe get some information from you all?
Yeah, I would urge you to go to the department for that information. They're the best judges of exactly what they need.
Do you feel like the way MedPAC is structured right now that you are adequately insulated from having members of Congress come in and tell you, here's what we think you really ought to be doing?
Well, we welcome our exchange with members of Congress, and the MedPAC staff works very closely with both the committee and personal staffs to understand congressional perspective. I have never felt undue pressure from any member of Congress.
You feel like you're adequately structured to be an independent entity, I guess that's what I'm
Absolutely.
asking.
Yeah.
Okay. Thanks, Mr. Chairman. That'll be it for me.
Thank you. Mr. Barrow?
Thank you, Mr. Chairman, and thank you, gentlemen, for being here today. I, too, along with Jim, had several other meetings this morning, so I apologize for being a little late, but I'm glad to have the chance to visit with you, and thank you for coming and offering your testimony. You know, fixing what's broke with Medicare Part D is a large part of comprehensive health care reform, and a lot of attention has been given to ways and means of trying to plug the donut hole, among other things. I want to focus on a problem with the Medicare Part D program that has bedeviled the people that I represent, that I hear about at every one of my town hall meetings. And that's the excessive degree of discretion and variety in the formularies that all of these various for-profit insurers are paid by the public, essentially, to assume a public risk, and the incredible confusion. You know, there's such a thing as too much of a good thing. And if there's too much variety and choice in the marketplace, you have a hard time finding what you need, and you have to do a lot of hunting and trying to find the drug that you want. And then with the potential for bait and switch that can exist and formulary being changed on you out of money after you've signed up, that just makes things so much worse. My question to you is, and I guess Chairman Hackbarth, you're probably in the best position to answer this, is any thought being given, since this is a public financed plan to get the for-profit insurance industry to compete with each other to make money trying to offer a benefits package to assume a public risk in providing this benefits package. Any thought given to trying to make more, to have a centralized or more standardized formulary that is comprehensive in its scope, but provides all of the necessary flexibility and variety to allow doctors to opt out when there's a medical necessity that they know about, a generally good reason to do so. But to make it clear that when folks go into this very confusing marketplace with so many people competing for the customer's business, that they know when that they're comparing apples to apples, they know that the benefits package is substantially the same, just as the entity that's paying for this is substantially the same, just as what you hope to get is substantially the same. Is any effort being made to do that?
Well, you're absolutely right that the choices that Medicare beneficiaries face are complicated in choosing among plans because of, among other things, differences in formularies. I would also add that it doesn't stop with the beneficiaries. You know, differences in formularies also have a significant impact on practicing physicians and how they deal with individual patients. What they prescribe needs to vary according to the plan that the patient is covered by, and that can be a real problem for physicians. There's a trade-off here, though. The flexibility around formularies and the exact benefit structure, those are tools that private plans can use to try to offer a better value for Medicare beneficiaries. Those are the tools that they can use to reduce the cost of the plan. And so there's a trade-off to be made. There's not
if you have a plan that's designed to the health profile of the patient, in theory, you can get yourself into a much smaller risk pool and be shopping for something that's just tailored for you. But the point is, it loses the quality of being insurance and takes on the quality of being sort of a revolving loan program.
Yeah. And some people have expressed concern in particular about specialty drugs, very high-cost drugs for patients with serious illnesses.
Well, if there's a medical necessity for that, the smaller the risk pool of folks buying into the program, the more expensive that's going to be when it is absolutely necessary to get it. So that sort of drives up the cost for those folks who need it when they need it. So I just what I'm getting at is if you really have too much choice, you don't know what you're choosing, and the other party on the other side of this deal can change the deal on you after you've signed up. We make this thing much more complicated, much less user-friendly than it has to be. And I want to make sure we're not driving up the cost by having exotic stuff driving up the cost for the ordinary everyday stuff. But there is a profile, there is a comprehensive scope of conditions that we can treat effectively, cost effectively with medication. And it seems to me the more we can eliminate the confusion in this, the more and make it genuinely available and comprehensive in its scope, the better service we're providing all our customers. Because after all, we're paying these folks to assume this public risk, and we ought to make sure that folks know what they're getting when they're going into the marketplace.
Mm-hmm.
What is MedPAC doing about this? Are y'all looking into this?
Well, on the specific issue of the complexity, we have looked at the choices that Medicare beneficiaries have to make in choosing among plans, and looked at the tools that beneficiaries have available to them. CMS does have some tools, as you know, to try to help beneficiaries compare plans and choices. We think here again, this is another area where some investment could pay dividends in helping beneficiaries understand their choices. There's no way around, though, the ultimate trade-off that you're going to face between complexity on the one hand and flexibility for plans to manage the costs on the other.
Well,
there's no right answer on how to strike that balance.
I think doctors...
Time is expired, but if you want to say something.
I just think doctors ought to be able to make those calls. Thank you, Mr. Chairman.
Thank you. Unless anyone else has questions, we're going to proceed to the next panel. So thank you very much. Your input is obviously very important as we proceed on this, and appreciate your being here this morning. Thank you. I'll ask the next panel to come forward.
Thanks for what you do. Good work.
Good job.
Thanks. My boss is out. Oh, okay. Thanks. Hi, Patty. Hi, how are you?
I'm
good
good.
to see you again.
Good to see you.
Thank you again for coming. Looks like you got the center down.
You get to sit next to each other. Well,
You'll do great. You always do.
Shawnee.
How are you, sir?
Good,
Hey,
how are
we're
you?
hot each other.
Good to see you too. Locked and loaded, good to go?
Hey,
Alyssa,
thank you so much for communicating with my son.
Thanks.
Yeah, I got followed up with.
How are you?
Good, good.
Good.
How are you?
Okay.
Good. See you?
Absolutely. All right. Just have them connected with me.
Sure, we'll just breeze right through.
Oh, yeah, you're over there. Gotcha. Should put big signs in front of each of us. Don't lean forward. How are you doing?
I'm doing fine, I think.
All right.
Could we ask that everyone be seated and that everyone else clear the room, because we do have to get moving. We have 3 more panels. Those who are talking and socializing, please leave the room.
I sure will, John.
How about down there?
Good to see you, too.
Fine, how are you? Yeah, exactly.
You still living over
Two staffers for every witness. Yeah. Yeah.
Oh, you got, are you in both places? Are you gonna clone and switch in too? They just had you. It's Robert. Where'd it go? I don't see you anymore. Let me sit down and get out of the way here. How's life in your neck of the woods? Crazy?
Busy.
Totally.
Yeah, as you probably imagine.
Yeah.
Been busy, so,
I saw Chip yesterday, and I said, I have a feeling the only way we're going to get the workhorse together again is if we have a reunion of our own. Yeah.
Yeah, we should do that.
Just pull up one of those chairs. Any one of them.
There we go.
Oh, okay.
Okay.
Oh.
Okay.
Oh, it was. You were absolutely right. Okay. We got to get him a chair.
Okay. Our second panel is on doctor, nurse, hospital, and other provider views. And as you can see, it's a rather large panel. So we want to get started. And let me, I don't think I've seen such a large panel. We'll start on my left with Dr. Ted Epperly, who is president of the American Academy of Family Physicians. And then we have Dr. M. Todd Williamson, who is president of the Medical Association of Georgia. And then is Dr. Carl Ulrich, who is clinical president and CEO of the Marshfield Clinic. And Dr. Janet Wright, who is vice president of science and quality at the American College of Cardiology. Dr. Kathleen White, who is chair of the Congress on Nursing Practice and Economics at the American Nurses Association. Dr. Gabbo, okay. Dr. Patricia Gabbo, who is Chief Executive Officer of the Denver Health and Hospital Authority for the National Association. Well, she'll be speaking for the National Association of Public Hospitals. Dan Hawkins, who is Senior Vice President, Public Policy and Research for the National Association of Community Health Centers. And Bruce Roberts, who is Executive Vice President and CEO of the National Community Pharmacists Association. Bruce Yarwood, President and CEO of the American Healthcare Association. And Alyssa Fox, who is Senior Vice President of the Office of Policy and Representation for the Blue Cross Blue Shield Association. Now, before we begin, I just wanted to point something out that I believe has been shared with staff, but I think needs to be repeated because of the panel. It would touch upon some of the things, particular with regard to community health centers. In several sections of the draft, well, I should say, in several sections of that part of the draft that deals with the public health and workforce development, in that division, a sentence that was supposed to be in addition to current authorizations was instead drafted to take the place of them. So instead of in addition, it says to take the place of in that division. And this is an error. It was caught on Friday afternoon, shortly after the draft was announced, and we did notify both Democrat and Republican committee staff of the mistake, and corrections have been sent to the Office of Legislative Counsel. But I did want to point that out before I started here today because I wasn't sure that all of you who are testifying were aware of that. The mistake is particularly glaring in the provision related to community health centers. And I think Mr. Hawkins knows this, but just let me point it out to everyone that the draft is supposed to include an additional $12 billion over 5 years in new money, and that's over and above the current appropriation. And again, that's why we have drafts, I guess. But let us start. As you know, we ask you to keep your comments, your oral comments to 5 minutes, and of course, all of your written testimony will be included in the record. And we'll start with Dr. Epperly.
Chairman Pallone, Ranking Member Deal, and members of the Energy and Commerce Health Subcommittee. I'm Ted Epperly, President of the American Academy of Family Physicians, which represents 94,600 members across the United States. I'm a practicing family physician from Boise, Idaho. I'm delighted to say that your draft bill goes a long way towards providing quality, affordable health care coverage for everyone in the United States. The AAFP has called for fundamental reform of our health care system for over 2 decades. We commend you for your leadership and commitment to find solutions to this complex national priority. We appreciate efforts to improve primary care through this draft bill. The Academy believes that making primary care the foundation of health care in this country is critical. Primary care is the only form of health delivery charged with the long-term care of the whole person and has the most effect on health care outcomes. Primary care is performed and managed by a personal physician, leading a team, collaborating with other health professionals, and using consultation or referral as needed. Many studies demonstrate that primary care is high quality and cost effective because it includes coordination and integration of health care services. The Academy believes the key to designing a new health care system is to emphasize the centrality of primary care by including the patient-centered medical home where every patient has a personal physician, emphasizing cognitive clinical decision-making rather than procedures, and ensuring the adequacy of our primary care workforce, and aligning incentives to embrace value over volume. Many of these key provisions are contained in your draft legislation. Specifically, we applaud the committee for including a medical home pilot program in Medicare as a step towards a primary care system. Your definition of the patient-centered medical home is consistent with the one established by the AAFP and other primary care organizations. We also support the PCMH demonstration project in Medicaid. Use of the medical home will achieve savings and improve quality. We appreciate the inclusion of a bonus of 5% for primary care services and up to 10% for services provided in a health profession shortage area. We urge you to make this bonus permanent. Medicare is a critical component of the U.S. health system and must be preserved and protected. With this draft, you take the first bold steps needed to remedy the Medicare physician payment system. The AAFP appreciates your recognition of the long-standing problems with the dysfunctional formula known as the Sustainable Growth Rate, or SGR. We thank you for proposing that it be rebased. This is an important, necessary, and welcome step. We also appreciate the bill's attention to workforce issues. Numerous studies indicate that more Americans depend on family physicians than on any other medical specialty. We are deeply concerned about the decline in the number of medical students pursuing a career in primary care at a time when the demand for primary care services will only be increasing. The majority of health care is provided in physicians' offices now and will be in the future. We must revitalize the programs to train the primary care physician workforce that will meet our needs in those locations. We thank you for reauthorizing and providing a substantial investment in the Section 747 of the Health Professions Primary Care Medicine Training Program. The National Health Care Workforce Commission in the discussion draft is needed to recommend the appropriate numbers and distribution of physicians. The AAFP is also pleased that the Medicaid title provides for a substantial expansion of coverage to the uninsured. In particular, we support increases to the Medicaid primary care payment so that it is equal to Medicare by 2012. The AAFP supports a public plan option consistent with the principles included in our written testimony. Patients should have a choice of health plans, and a public plan should be one of them. However, the public plan should not be Medicare. We acknowledge that for transition purposes, there may be some similarities to the federal program, but we urge Congress to delink the public plan from Medicare by a date certain. The AAFP strongly supports the inclusion of comparative effectiveness research in the draft bill. We appreciate the establishment of a center within the Agency for Healthcare Research and Quality. If we wish to improve the patient care and control costs in this country, this type of research is crucial. It is only with CER that we can provide evidence-based information to patients and physicians for use in making health care decisions. Finally, we support a number of insurance market changes that will help our patients in regards to the health insurance exchange, where they can one-stop shop for a health care plan, a sliding scale subsidy so that people can purchase meaningful coverage, guaranteed availability and renewability of coverage, prohibition of pre-existing conditions, exclusions, and denials, and benefit packages that allow consumers to select the one that best meets their needs, as well as a requirement for a core set of benefits. In conclusion, the Academy believes that health care should be a shared responsibility and applauds the section of the bill that requires all individuals have coverage. Now is the time to provide affordable, high-quality health care coverage. The status quo is not working. We urge Congress to invest in the health care system we want, not the one we have. Thank you very much, Mr. Chairman.
Thank you, Dr. Epperly. Dr. Williamson.
Good morning, Chairman Pallone and Mr. Deal. My name is Todd Williamson, and I want to thank you for the opportunity to speak to you today. I'm a neurologist from Atlanta, and I serve as the president of the Medical Association of Georgia, and I'm speaking on behalf of that association. I recently had the privilege of speaking on behalf of a coalition of 20 state and specialty medical societies representing more than 100,000 physicians, which is nearly half of the practicing physicians in the United States. This coalition believes that ensuring the patient's right to privately contract with their physician is the single most important step we could take to reform our medical care system. I would like to begin by addressing 3 assumptions that underpin the discussion draft. The first relates to geographic disparities in spending. Peter Orszag recently said that nearly 30% of Medicare's costs could be saved without negatively affecting health outcomes if spending in high and medium cost areas could be reduced to the level in low cost areas. We do not agree. This flawed claim was first made by the Dartmouth Group, which used only Medicare data to analyze spending and quality. Please consider the work of Dr. Richard Cooper, which shows that an examination of total medical spending per capita reveals that quality and costs are indeed connected. He also demonstrates that Medicare payments are disproportionately higher in states with high poverty levels and low overall medical care spending. The suggestion that our medical care expenditures are greater than other countries is also misleading. Countries account for expenditures such as out-of-pocket payments and the cost of long-term care in different ways. Some countries drive down costs by rationing care. The cost of research and development distorts our expenditures as well. A third faulty assumption is that medical care outcomes in the United States are worse than in other countries. America's often cited infant mortality statistics cannot be directly compared to statistics from other countries that do not record the deaths of low birth weight newborns that we try to save. Comparisons of a host of specific diseases such as diabetes clearly show our outcomes are superior. We cannot support and would actively oppose the discussion draft. As I noted, we believe that allowing patients and physicians to privately contract is the single most important step we can take towards reforming the nation's medical care system. This will empower patients to choose their physician, spend their own money on medical care, and make their own medical decisions. Medical expenditures can only be appropriately controlled and allocated where there is complete transparency and acknowledgement of necessity and value at the time of the patient-physician interaction. Private contracting will enhance access to medical care. Many physicians opt out of government plans because payments do not cover costs. If private contracting was allowed, every patient would have access to every doctor. This option is currently not available under government plans and is prohibited in the discussion draft. Critics cite that private contracting will disadvantage impoverished patients. I would argue that they will benefit from increased access and competition in the medical community, and their physicians will be at liberty to waive copays, which is currently forbidden in government plans. We applaud the draft sponsors for planning to rebase the SGR payment system, but we remain concerned that they continue to rely on a target-based approach. We support the emphasis on prevention, wellness, and claims transparency. We agree that primary care should receive greater support and administrative burden should be reduced. We do not believe that the federal government should replace current research and development mechanisms or the training and judgment of physicians with federally controlled comparative effectiveness research. While we recognize the need for reform, we believe that the private marketplace should remain the primary means of obtaining insurance. A government-sponsored health insurance program for working-age adults will invariably eliminate private options. Recall that Medicare was originally introduced as an option for seniors, but today it has essentially become their only choice. We can reduce obstacles to individual ownership and control of medical insurance by adopting new tax policies. This would eliminate the phenomenon of pre-existing conditions because individuals could carry their insurance with them for life, independent of their occupation or employer. To those who assert that the private sector has failed our patients, I say that our patients have been disadvantaged in the marketplace by a tax system that penalizes individual ownership of health insurance.
When all Americans own their policies, insurance companies will be forced to compete for the business of millions of individuals, and they will focus on satisfying the patient, not the patient's employer. Finally, we can significantly reduce health care expenditures and improve access by enacting proven, effective medical liability reform measures. I appreciate this opportunity to present the views of practicing physicians to you today. Thank you.
Thank you, Dr. Williamson. Dr. Ulrich. Or is it Ulrich or Ulrich?
Ulrich is correct.
Ulrich.
Thank you. Mr. Chairman, Ranking Member Deal, and members of the subcommittee, my name is Carl Ulrich, and I am President and CEO of Marshfield Clinic in Marshfield, Wisconsin. On behalf of myself, our staff, and the tens of thousands of patients that we care for, we commend you for advancing the national health reform debate. At our clinic, we continue to follow closely this dialogue, especially reorienting the system towards quality and efficiency, while at the same time ensuring that any meaningful reform is not built upon the flawed incentives of the current program. Therefore, we strongly urge this committee to be bold and address the problems of affordability, quality, and disparities in payment that plague the program, hurting beneficiaries and providers alike. As background, Marshfield Clinic is one of the largest medical group practices in Wisconsin and indeed the United States, with almost 800 physicians, 6,500 additional staff, and 3.6 million annual patient encounters per year. As a 501c3 not-for-profit organization, our clinic is a public trust, serving all who seek care regardless of their ability to pay. As part of our commitment, the clinic has invested in sophisticated tools that complement and support our mission, such as an internally developed certified electronic medical record, a data warehouse, and an immunization registry. With this infrastructure, the clinic is presently publicly reporting clinical outcomes and providing quality improvement tools to analyze processes, eliminate waste, and improve consistency while still reducing unnecessary costs. These initiatives are consistent with the stated goals of the national health reform debate. Our clinic has long used information to facilitate care redesign, and we expanded these efforts after becoming a participant in the federal physician group practice demonstration. As a result, we have improved care, reduced costs, and achieved significant savings for the Medicare program. In the first 2 years of the demonstration, we have saved taxpayers more than $25 million with our redesigns, while meeting or exceeding all 27 of possible quality metrics. We believe that equivalent or even greater results are possible with the creation of the proposed accountable care organizations, especially if the subcommittee aligns the incentives of the Medicare program reimbursement with value and efficiency. However, of concern is the current tri-committee mark. The authors have proposed the establishment of a public health insurance option. Providers who voluntarily participate in Medicare would be required to participate in the public option and would be paid at Medicare rates plus some incremental percentage for the first 3 years of operation. This raises substantial financial and operational questions around how the federal government could compel physicians to see those patients. For instance, would this mean that patients must be seen when they present, or would providers be compelled to see the patient within a certain time frame? Further, if the public plan pays at Medicare rates, the reduction in commercial service revenue would compel radical restructuring of our institution, perhaps resulting in our demise. As such, and in this current form, Marshfield Clinic strongly opposes the public plan alternative based on the belief that a true level playing field could never exist between public and private providers. In Wisconsin, where commercial rates vary between 180 to 280% of Medicare rates, this public plan would have such a profound competitive advantage that one needs to be concerned that providers would uniformly abandon the Medicare program to survive in the practice of medicine. Further, there is a significant problem with Medicare payment rates in Wisconsin as well as the rest of rural America. For example, Medicare currently reimburses us at only 51.6% of our allowable costs. We believe that this is a result of Medicare's failed formulas for reimbursing physician work and practice expense and Medicare's geographic adjustment. To address these systemic problems, we believe that Congress and CMS must refine Medicare payment systems to address the problems of access and encourage appropriate care by providing incentives that focus on quality and efficiency. Similarly, we are also concerned about the practice expense components of the Medicare physician formula. It is widely agreed that the data used to estimate non-physician wages does not reflect current patterns in practice of medicine. As a result, the formula distorts payments, paying some too much and others too little. To resolve this disparity, we would like to heighten the legislative work of Congressman Braley and Kind, who have each authored legislation to correct this inequity. And we urge the subcommittee to include these members as thoughtful provisions in any health care reform legislation that advances. Again, Marshfield Clinic appreciates the opportunity to share our views, and we look forward to advancing our shared vision of a healthy America. Thank you.
Thank you, Dr. Ulrich. Dr. Wright.
Chairman Pallone and Ranking Member Deal and members of the subcommittee, thank you for the opportunity to appear before the subcommittee today. My name is Janet Wright. I'm a board-certified cardiologist, having trained in San Francisco and practiced in Northern California for 25 years. For the last year, I've been serving as the American College of Cardiology's Senior Vice President for Science and Quality here in Washington. And in that role, I oversee our registries, our scientific documents like guidelines and performance measures and appropriate use criteria, and also our quality improvement projects and programs. On behalf of the 37,000 members of the ACC, I commend you for setting out the healthcare reforms in the current draft bill. We see so many improvements, and we commend you and applaud your efforts to both attend to and correct the flawed physician payment model. We also register concerns about proposed cuts in imaging and the effect they may have on patients' access to care. But in broad overview, the ACC is completely committed to comprehensive reform, and we are very grateful for your attention to the matter. Ranking Member Barton invited me to speak today about his draft proposal, the Healthcare Transparency Commission Act of 2009, and I'm delighted to offer these comments. The American College of Cardiology values performance measurement, its analysis and improvement, and it demonstrates this commitment through a 25-year history of producing guidelines for clinical practice, the more recent generation of a particular kind of guidance called appropriate use criteria, to help clinicians choose the appropriate type of treatment or technology or procedure that best fits that patient's clinical scenario. And then our efforts in what's now called implementation science, taking what we know works and trying to get that into the practice of medicine in a systematic way. Examples of that in recent years are the Door to Balloon project of the Alliance for Quality, over 1,100 hospitals here in the U.S. and beyond, trying to shorten up that time from diagnosis of a myocardial infarction until the balloon opens that artery. And more recently, we are about to launch a program called Hospital to Home, Excellence in Transition, along with key partnerships, particularly with the Institute for Healthcare Improvement. And finally, we're beginning to implement our appropriate use criteria, both in imaging and soon in revascularization, to help clinicians, their patients, and their surgeons make good decisions about revascularization. In fact, our vision is not just separate projects, but a network of practices and hospitals. We're currently in about our registries are in about 2,300 hospitals around the country, and our ambulatory registry quality improvement program is just beginning, but we're out into about 600 practices in the country. Our fully realized vision is to connect these practices and hospitals in a quality network. Those individuals practicing in the hospitals and outpatient settings are committed to the systematic delivery of scientifically sound, patient-centered care. And fully realize that vision will include a primary care network as well, because we understand most of cardiac disease is actually managed by primary care docs and nurses. In order to effect this vision, to make this come true, obviously payment needs to be readjusted from the volume that we've known to the value that we treasure. I enlist and again appreciate your efforts to make that happen. We believe that good data are the foundation for quality improvement and serve to stimulate innovation, very healthy competition amongst providers, and rapid and continuous learning network. As the science of performance measurement improves, and the skill of all of us at communicating complicated statistics to lay people, as that skill is honed, consumers will likewise find great value in quality information. The ACC strongly supports the public's right to valid, actionable, and current data to help inform and enhance decision making. We find Mr. Barton's proposal to be a laudable one, and should Congress proceed in this direction, we recommend consideration of the following principles. These were published in 2008, and I'm only going to hit the high points. But number one, these 5 principles. Number one, the driving force for performance measurement and public reporting should be quality improvement. We acknowledge and support Mr. Barton's critical inclusion in his draft bill of quality ratings along with pricing information. Number 2, public reporting programs should be based on performance measures with scientific validity. Number 3, public reporting programs should be developed in partnership with healthcare professionals, those being measured. Number 4, every effort should be made to use standardized data elements to assess and report performance, and to make the submission process uniform across all public reporting programs. This helps reduce the measurement fatigue and the disengagement that we often see in healthcare professionals who are exhausted with the effort of measuring. Number 5, performance reporting should occur at the appropriate level of accountability. I think this is true in all areas of medicine, but certainly in cardiology, the most effective care is delivered by teams. Focusing on an individual within that team may skew the measurement and the result of that measurement in a way that has adverse consequences.
Dr. White, you're almost a minute over, so if you could just summarize.
Number 6 is avoiding those unintended consequences. Thank you very much.
Thank you. Sorry. Dr. White. Your mic is not on. You have to turn that green light on and then bring the mic a little closer. Yeah.
Chairman Pallone, Ranking Member Deal, distinguished committee members and congressional staff. I'm Kathleen White, a registered nurse speaking today on behalf of the American Nurses Association, and we thank you for this opportunity to testify. The ANA is the only full-service national association representing the interests of the nation's 2.9 million registered nurses in all educational and practice settings. ANA advances the nursing profession by fostering high standards of nursing practice. ANA commends the committee for its work in the Tri-Committee's draft legislation, which represents a movement toward much-needed, comprehensive, and meaningful reform for our healthcare system. We appreciate the committee's recognition that in order to meet our nation's healthcare needs, that we must have an integrated and well-resourced national workforce policy that fully recognizes the vital role of nurses and other healthcare providers and allows each to practice to the fullest extent of their scope. ANA remains committed to the principle that health care is a basic human right and all persons are entitled to ready access to affordable, quality health care services that are patient-centered, comprehensive, and accessible. We also support a restructured health care system that ensures universal access to a standard package of essential health care services for all. That is why ANA strongly supports the inclusion of a public health insurance plan option as an essential component of comprehensive health care reform. We believe that inclusion of a public plan option would assure that patient choice is a reality and not an empty promise, and that a high-quality public plan option will, above all, provide the peace of mind that is missing from our current health care environment. It will guarantee the availability of quality, affordable coverage for individuals and families no matter what happens, and generate needed competition in the insurance market. ANA looks forward to partnering with you to make this plan a reality. There are a wide variety of ideas currently circulating on health care reform, but all include discussion of prevention and screening, health education, chronic disease management, coordination of care, and the provision of community-based primary care. As the committee has clearly recognized in its drafts, these are precisely the professional skills and services that registered nurses bring to patient care. As the largest group of healthcare professionals, registered nurses are educated and practice within a holistic framework that views the individual, family, and community as an interconnected system. Nurses are the backbone of the healthcare system and are fundamental to the critical shift needed in health services delivery, with the goal of transforming the current sick care system into a true healthcare system. ANA deeply appreciates the committee's recognition of the need to expand the nursing workforce and thanks you for your commitment to amend the Title VIII Nursing Workforce Development Programs under the Public Health Service Act and commend the inclusion of the definition of nurse-managed health centers under the Title VIII definitions. We applaud the removal of the 10% cap on doctoral traineeships under the Advanced Education Nursing Grant Program and the inclusion of special consideration to eligible entities that increase diversity among advanced educated nurses. Additionally, the expansion of the loan repayment program eligibility to include graduates who commit to serving as nurse faculty for 2 years will help address this critical shortage of both bedside nurses and nursing faculty. We're also grateful for the funding stream created through the Public Health Investment Fund and the commitment of dollars through 2014 that would offer vital resources and much-needed funding stability for these Title VIII programs. ANA applauds the use of community-based multidisciplinary teams to support primary care through the medical home model. ANA is especially pleased that under this proposal, nurse practitioners have been recognized as primary care providers and authorized to lead medical homes. Nurse practitioners' skills and education, which emphasize patient and family-centered whole-person care, make them particularly well-suited providers to lead in the medical home model, focused on coordinated chronic care management and wellness and prevention. Many recent studies have demonstrated what most healthcare consumers already know. Nursing care and quality patient care are inextricably linked in all care settings, but particularly in acute and long-term care. Because nursing care is fundamental to patient outcomes, we're pleased that the legislation places strong emphasis on reporting nurse staffing in long-term care settings, both publicly and to the Secretary. The availability of nurse staffing information on the Nursing Home Compare website would be vital to help consumers make informed decisions, and the full data reported to the Secretary will ensure staffing accountability and enhance resident safety. ANA hopes that in the same vein, the committee will look toward incorporating public reporting of similar nurse staffing measures and nursing sensitive indicators in acute care through the Hospital Compare website, as recommended by the National Quality Forum. Finally, a reformed healthcare system must value primary care and prevention to achieve improved health status of individuals, families, and the community. ANA supports the renewed focus on new and existing community-based programs, such as community health centers, nurse home visitation programs, and school-based clinics, and applauds the committee's recognition of the vital importance of addressing health disparities. Once again, the American Nurses Association thanks you for the opportunity to testify before this committee. We appreciate your understanding of the important role nurses play in the lives of our patients and the health system at large. Nurses are ready to work with you to support and advance meaningful health care reform today. Thank you.
Thank you, Dr. White. Dr. Gabel?
Chairman Pallone, Ranking Member Deal, and members of the committee, thank you for the opportunity to testify. I'm Dr. Patricia Gabo, and I'm speaking for Denver Health and the National Association of Public Health and Hospital System. Please excuse my voice. Denver Health is an integrated safety net institution that includes the state's busiest hospitals, all Denver's federally qualified health centers, the public health department, all the school-based clinics, and more. Since 1991, we have provided $3.4 billion in uninsured care and have been in the black every year. We have state-of-the-art facilities and sophisticated HIT. These characteristics have enabled amazing quality. 92% of our children are immunized. Our hospital mortality is one of the lowest in the country. 61% of our patients have their blood pressure controlled compared to 34% in the country. This is despite the fact that 46% of our patients are uninsured, 70% are minorities, and 85% are below 185% of federal poverty level. So you may ask, if we are doing so well and meeting patients' needs, why am I here supporting health reform? The answer is straightforward. As a safety net physician leader, I see every day that America is failing to meet people's health care needs in a coordinated, high-quality, low-cost way. The number of uninsured at our door and the cost of their care increases every year. In 2007, our uninsured care was $275 million. Last year, it was $318 million and is projected to be $360 million this year. This is not sustainable. Moreover, not every American city has a Denver Health. As a doctor, I ask myself, why should where you live in America determine if you live? Why should an uninsured cancer patient get care if they live in Denver, but not if they live in another Colorado county? You have included important reform components in your draft bill. We support your goal to ensure affordable quality care for all. I agree that costs must be reduced if we are to cover everyone, and costs can be reduced by developing integrated systems that get patients to the right place at the right time with the right level of care, with the right provider, and the right financial incentives. We support your continued investment in DISH hospitals, community health centers, and public health. I would encourage incentives to move these separate entities to integrated systems. These entities will be important during the transition to full coverage and afterwards to vulnerable patients, including Medicaid, which will be a building block for much of the coverage expansion. Integrated systems are cost efficient. Our charges per Medicaid admission are 30% below our peer hospitals. Your investment in primary care and nurse training and the National Health Service Corps is critical. Without this, we will not be able to get patients to the right provider for the right level of care. As a public entity, we believe in the power of the public sector to meet the needs not only of those patients on public programs, but also private patients. We are the major Medicaid provider for our state, but our HMO also serves private patients, including Denver's mayors. We and other safety net systems would welcome the opportunity to continue to be a plan of choice. In summary, as a physician and a CEO of a public safety net system, I urge you to continue this effort to substantially reform our delivery system, our payment model, and to provide care for all Americans. Our current system cannot and should not be sustained. America deserves better. I and NAPH are eager to help you in this very important task. Thank you.
Thank you, Doctor. Mr. Hawkins.
Well said, Dr. Gubbo. Good morning, Mr. Chairman, Ranking Member Deal, and distinguished members of the subcommittee. Distinguished meaning president accounted for. On behalf of the National Association of Community Health Centers, the nation's more than 1,200 community health center organizations, and the more than 18 million people they serve today, thank you for the opportunity to contribute to today's discussion. In community health centers all across the country, we witness the urgent need for fundamental health reform every single day. In the faces and the struggles of our patients who for too long have been left behind by our dysfunctional healthcare system. Our 43 years' experience in caring for America's medically disenfranchised and underserved has taught us three things. First and foremost, that health reform must achieve universal coverage that is available and affordable for everyone, and especially for low-income individuals and families. Second, that coverage must be comprehensive and must emphasize prevention and primary care. And third, that it must guarantee that everyone has access to a medical or a health care home where they can receive high-quality, cost-effective care for their needs. Mr. Chairman, we believe that the plan we have before us today meets those principles and also moves our nation much closer to achieving the equity and social justice in healthcare that has proven so elusive over the past century. Community health centers strongly support the draft legislation's call to expand Medicaid to cover everyone with incomes up to 133% of poverty without restriction. This Medicaid expansion may well be the most important and the most essential feature of this plan, especially for the patients we serve. At the same time, we urge you to ensure that, as these Medicaid beneficiaries are potentially moved into the health insurance exchange, they can continue receiving as supplemental Medicaid benefits those key services like outreach, transportation, nutrition, and health education, screening, and case management that will remain so vital to their health and well-being, but will most likely not be covered by their exchange plans. It is also clear that the expansion of insurance coverage, while a vital first step, can only take the country so far. Most importantly, the increased demand for care that comes from expanding coverage must be met with an augmented primary health care system, as the people of Massachusetts learned in the wake of their state's reform. Here again, the draft legislation delivers a solid response to this challenge, and we applaud its call to expand the health center system of care through increased funding as part of the new Public Health Investment Fund. The members of this committee have consistently provided broad, bipartisan support for health centers over the years, and we deeply appreciate that. And I can assure you that health centers are repaying your trust and your investment in them every day. For example, a recent national study done in collaboration with the Robert Graham Center found that people who use health centers as their usual source of care have 41% lower total health care costs and expenditures than people who get their care elsewhere. As a result, health centers saved the health care system $18 billion last year alone, more than 9 times the federal appropriation for the program, and better than $2 for every dollar they spent in care. With the new funding in the draft bill, these savings will grow even larger. The National Health Service Corps is a vital tool for health centers and underserved communities seeking to recruit new clinicians. And the draft legislation would bring an historic investment to the program, leading to thousands more primary care providers to practice in underserved communities. The committee has also historically recognized that it makes sense for all insurers to reimburse health centers and other safety net providers appropriately and predictably for the comprehensive primary and preventive care they provide. In order to accomplish this goal, we recommend that Congress align health center payments from all insurers, public and private, with the structure currently in place under Medicaid. As you continue deliberations, we urge the committee to consider improving the bill further by including language from H.R. 1643, which would align the current Medicare health center payment methodology with the successful Medicaid prospective payment system. Finally, as full participants in a reformed health care system, America's health centers stand ready to deliver quality improvement, increased access, and cost containment that will be necessary to make this reform successful. To that end, we applaud the committee's inclusion of network adequacy standards for all exchange plans to ensure that people living in underserved communities have access to the health centers and other essential community providers located there. Mr. Chairman and members of the committee, we again thank you for your leadership and your commitment to make health care reform work for all Americans, and we pledge ourselves to work with you to make that a reality this year. Thank you.
Thank you, Mr. Hawkins. Mr. Roberts.
Chairman Pallone, Congressman Deal, and members of the Health Subcommittee, I'm Bruce Roberts, the Executive Vice President and CEO of the National Community Pharmacists Association, NCPA. I'm a licensed pharmacist in the state of Virginia, and I've owned 4 community pharmacies over the last 33 years in Loudoun County, Virginia. NCPA represents the owners and operators of 23,000 independent community pharmacies in the United States. We appreciate the opportunity to testify before you today on the role of pharmacy in healthcare reform. In many communities throughout the United States, especially in urban and rural areas, independent community pharmacies are often the primary source of a broad range of healthcare products and services. Services such as medication therapy management and immunization programs for seniors under Medicare Part B and D, We believe that a reformed healthcare system should expand the availability of these programs because they can help improve the quality of care and reduce healthcare cost. The reality is that for every dollar the healthcare system spends paying for prescription medications, we spend at least another additional dollar on healthcare services to treat the adverse effects of medications that are taken incorrectly or not at all. For example, a primary cause for costly hospital readmissions is the lack of patient adherence to medications used to treat chronic medical conditions such as hypertension and high cholesterol. Pharmacists can play an important role in the post-acute care in helping patients manage their medications through education, training, and monitoring. We applaud the fact that the draft House language would allow the involvement of non-physician practitioners, such as pharmacists, in the medical home pilot project. Pharmacists can help improve the use of prescription medications, especially in those individuals that have multiple chronic diseases. NCPA is very much appreciates the fact that that draft House legislation includes reform of the average manufacturer's price, AMP, based reimbursement system for Medicaid generic drugs. We would like to get this fixed this year. We are concerned that the Medicaid generic reimbursement at 130% of the weighted average AMP as proposed in the draft House bill, combined with low dispensing fees paid by states, will in total still significantly underpay pharmacies for the dispensing of low-cost generics in the Medicaid program. This could create a disincentive for the use of generic drugs, causing a rise in Medicaid costs over the long term. NCPA asked the committee to consider a higher FUL reimbursement rate for generic medications, especially for critical access community pharmacies that serve a higher percentage of the Medicaid recipients or rural pharmacies. With respect to our ability to continue to provide durable medical equipment, DME, to Medicare beneficiaries, we believe that the requiring state-licensed, state-supervised community retail pharmacies to obtain both accreditation and surety bonds to simply sell DMEPOST items such as diabetes testing supplies to Medicare beneficiaries is basically overkill. Thousands of pharmacies across the country, mostly small pharmacies, will not be accredited at all or not be finished the accreditation process by October 1st, which will mean that they will not be able to provide diabetes testing supplies for Medicare beneficiaries. We applaud the 90 bipartisan members of the House and 13 members of the Energy and Commerce Committee who supported H.R. 616, the bill that was introduced by Congressman Berry and Congressman Moran that would exempt pharmacies from redundant and unnecessary accreditation requirements. We also appreciate the work of Congressman Space in introducing H.R. 1970, which would exempt pharmacies from the unnecessary surety bonds. We ask that the provisions from these bills be included in the Chairman's mark. If there is a willingness to exempt pharmacies from these requirements, we ask that Congress consider acting by October 1st, which is the deadline for providers to attain accreditation and surety bond. Finally, I would make a few comments regarding the public plan option. Under the House proposal, payment rates for prescription drugs under the public plan proposal would be negotiated by the Secretary. We would be very concerned giving the Secretary authority to set payment rates for prescription drugs without some basic guidance to how these rates should be established and updated. We also ask that the language be clarified such as the administration of any benefit under the public plan would be accomplished by a pharmacy benefit administrator as opposed to a pharmacy benefit manager. We would prefer a model used in the Medicaid program or in the Department of Defense TRICARE program where the administrator is used. Under this model, most, if not all, the negotiated drug manufacturer rebates would be passed through to the public program. In conclusion, we look forward to working with Congress and the administration to reform the healthcare system, and we look forward to the opportunity to work with you to meet that end.
Thank you, Mr. Roberts. Mr. Yarwood.
Yes, sir. Am I on? There we go. That do it?
Is the mic on? You have to...
Huh?
Or maybe bring it closer. Is the green light on?
Is that, we got it?
That's good.
Okay, shoot. I'm afraid you'll hear me. I should first of all say thank you for including me in the distinguished panel. I'm a doctor, pharmacy, and here's old Yarwood sitting right in between them all. But thank you very much. Appreciate this being here. As you know, I'm Bruce Yarwood. I'm President and CEO of the American Healthcare Association and National Center for Assisted Living, which we represent about 11,000 facilities across the country with a great cross-section of the profession. We have big, we have small, we have rural, we have urban, proprietary, non-proprietary. And I would be remiss if I didn't say we look at ourselves as a pretty significant force in the economy right now. We're about 1.1% of the gross domestic product when you kind of sort it all out. Now, having said that, we've taken a look at the 800 pages, and it's a significant bill. And I must admit, one that does not include long-term care reform as a reform. At the same time, it includes a whole bunch of stuff that has impact on us. And let me try to synthesize a little bit of the comments. First, as we move forward and try to do a better job in terms of quality, it's really important for us to have economic stability. And one of the things we find in the bill is we have three pretty big problems with it. First of all, the bill has a provision that would institutionalize what the CMS is doing to cut 3.3% out of our Medicare rate, based on a formulary mistake that was made by them 4 years ago. Secondly, we're concerned about the discussion draft that will eliminate a part of the market basket. And so what we're looking at then is not only a 3.3% cut in our rate coming from CMS, but then an additional cut coming from the committee that would significantly take resources out in terms of our ability to pay. And as you know, we are 2/3 to 3/4%, or 75% labor-based. And so a significant reduction in reimbursement causes us a big problem in terms of our ability to pay and keep staff. Third, which is not your doing, but Medicare cuts are being considered at the same time. We're looking at what we call the unfortunate reality of Medicaid underfunding. What we have seen, the stimulus package was a help. However, in response to the recession, we see 46% of the states are freezing or cutting nursing home rates, and that the 75% are not keeping up with inflation. So in the shortfall, or in a short statement, what's occurring is that we're looking down the barrel of a Medicare cut. At the same time, we're looking across the country of Medicaid rates either staying stable or falling in a period of inflation. And so we're feeling caught in an economic vice, if you will. Now, let me talk a little bit about some other stuff that is I would say, very positive. Regarding Part B, we applaud you for the proposing to extend the therapy cap exception process. Second, I think in testimony earlier we talked about Medicare rehospitalization. We have a rehospitalization problem, and we need to jointly address that issue. We think there are ways to do that. In a short statement, we find that our rehospitalization comes on day 2, 3, and 4 of admission. And typically they go back to the hospital because we probably shouldn't have taken, or they come on the weekend, or things of that nature. So we think we should continue to work on that together. Third, we think that we should be looking at the whole post-acute setting and trying to integrate that much better than it is now. And we have numbers that would show that if we, either on a pilot or demonstration basis, I don't care from what you were talking about before, but we find that if we would integrate and pay based on diagnosis, not on site, we can save multi-billion dollars, ranging above $50 billion over the next 10 years. And that's simply stated is that we can take a knee or a hip that is not an IRF but in a nursing home and do it for about half the cost. I would be remiss if I didn't respond a little bit to 100 pages of your bill that was addressed somewhat earlier by the prior panel that talks about transparency in long-term care. Very, very basically put, the question is that what we need to do is take a lot better look at who owns places, how they're owned, who makes the decisions. We've been in discussions with the staff for about the last 18 months, and frankly, we support the concept and the direction of the committee, and we believe firmly that by continuing to work together, the final legislation that we can parse together, we can absolutely support. I would say there are a few specifics, though, that I say I'd be remiss if I didn't say that we have a problem with. First, we have a difficult time with what's a disclosable party. And in the bill itself, for example, it mentions that we should be disclosing our bankers' boards of directors. That's something we really don't have or can't get to. Secondly, we would suggest the provisions that you're looking at be tailored to talk about exactly who we want to disclose. We take a look at the bill, and we're in the position of disclosing people like who our landscapers are, painters are, and things of that nature that don't have a significant amount. So we think we can work that out. Third, we heard a lot about compliance programs from the Inspector General. We have no problem with compliance programs, but what we need is tailor those based on the size of the facility. A compliance program for Kindred Healthcare that's the largest in the country versus a compliance program for a 35-bed facility in Oakland are two different things. So we just need to be sympathetic as to what those are.
You're a minute over. Yeah, by a minute.
Well, then let me say this. Thank you very much for letting us be here. We certainly want to work together, and there's some great things in the workforce area and as the transparency stuff, we're here to make it work for you.
Thank you. Thanks a lot. Ms. Fox.
Oh, sorry.
Thank you very much, Chairman Pallone, Ranking Member Deal, and other members of the committee. I really appreciate the opportunity to be here today. Blue Cross Blue Shield plans strongly support enactment of health reform. We must rein in costs, improve quality, and importantly, we must cover everyone. Today, the Blue system provides coverage to more than 100 million people in every community and every zip code in this country. For the past 2 years, we have been supporting 5 key steps to reform our system. First, we believe Congress should encourage research on what treatments work best by establishing a Comparative Effectiveness Research Institute. We are very pleased the House draft bill recognizes the importance of this key step. Second, in order to attack rising costs, we must change the incentives in the payment systems, both private and in Medicare, to promote better care instead of just more services. The draft bill includes some of the Medicare delivery system recommendations we support. We also agree with provisions in the bill to help build an adequate medical workforce to care for everyone in the country. Third, consumers and providers should be empowered with information and tools to make more informed decisions. Fourth, we need to promote health and wellness and prevention and manage care for those with chronic illnesses. Finally, we believe a combination of public and private coverage solutions are needed to make sure everyone is covered. We support a new individual responsibility program for all Americans to obtain coverage, along with subsidies to ensure coverage is affordable. We also support expanding Medicaid to cover everyone in poverty. We are also supporting major reforms in our own industry, including new federal rules to require insurers to open the doors, accept everyone, regardless of pre-existing conditions, and eliminate the practice of varying premiums based upon health status. And we also support a national system of state exchanges to make it easier for individuals and small employers to purchase coverage. I know there's a perception that this is a new position for the insurance industry. It's not for the Blue system. We had the same position in 1993. We appreciate this opportunity to comment on the Tri-Committee bill. We support the broad framework of the bill, which includes many of the critical steps we believe are needed. However, we have very strong concerns that specific provisions will have serious unintended consequences that will undermine the committee's goals. Our chief concern is creation of a new government-run health program. We believe a government-run health program is unnecessary for reform and will be very problematic for 3 reasons. First, many people are likely to lose the private coverage they like and be shifted into the government plan. This is because the government plan will have many price advantages that private plans won't, including paying much lower Medicare rates than the private sector. This is an enormous advantage on its own, as Medicare rates are already 20 to 30% lower than what we pay in the private side, and that's a national average. I think here you heard Marshfield Clinic talk about much huger variations in Wisconsin. But there are other advantages in the bill as well. I'll give you 2 examples. Individuals in the government plan, they can only sue in federal court for the denied services. However, individuals in private plans can sue in state court for punitive, compensatory, and other damages. In addition, private plans would have to meet 1,800 separate state benefit and provider requirements, while the government plan would not. Second, the draft bill would underpay providers in the government plan. This is likely to lead to major access issues in the healthcare system, such as long waits for services. And third, the government plan would undermine much-needed delivery system reforms that are critical to controlling costs. We agree Medicare needs to be reformed to reward high-quality care. We commend the committees for including reforms to modernize Medicare. However, history has shown the government can be slow to innovate and implement changes due to the complex legislative and regulatory processes. The private sector, on the other hand, is free to innovate. And let me just give you one example from our program that is improving outcomes and lowering costs through our Blue Distinction Centers of Excellence. Recent data shows that readmission rates at our cardiac care centers around the country have 26 to 37% lower readmission rates than other hospitals. In closing, I would like to emphasize the Blue System's strong support for healthcare reform, including major changes in how insurers do business today. We believe the federal government has a vital and expanded role to play in reform by expanding Medicaid to cover everyone in poverty and enrolling all the people that are now eligible for Medicaid coverage. By reforming Medicare to pay for quality and assuring Medicare's long-term solvency, and setting strict new rules for insurers to assure access to everyone regardless of their health. We are committed to working with all of you to enact meaningful healthcare reform this year. Thank you very much.
Thank you, Ms. Fox. And now we'll have questions, starting with me. Obviously, I can't reach everyone, so I'm going to direct my question. I would try to get in 3 questions about primary care, Medicaid, and DISH, if I could. And I'm going to start with Dr. Epperly on the primary care promotion issue. We've obviously heard a lot of testimony about the primary care shortage. We've heard that action on a single front is not enough, but that concerted action across the health system is going to be required. And the discussion draft reflects these calls for action. It proposes major investments, and I'll list first in increasing the rate paid by Medicaid for primary care services. Second, the primary care workforce, including increases for the National Health Service Corps and scholarship and loan programs. Third, payment increases in Medicare and the public option for primary care practitioners, including an immediate 5% increase in payments and high growth allowances under a reformed physician fee schedule. Fourth, an additional payment incentive for primary care physicians in health profession shortage areas. And finally, an expansion of medical home payments and added flexibility for that model of care. The draft also proposes a reform to graduate medical education programs funded by Medicare and Medicaid. 2 questions. First, will these proposals help to reverse the decline in interest in primary care among medical students? Dr. Epperly.
Absolutely.
Okay.
Did you want me to expand on that? Or
yeah, well, let me give you the second one, and then you can talk. The second was, will the rate increases proposed for primary care services in Medicaid and Medicare help to address problems with access we've seen in those programs over the past several years? So generally, will you reverse the decline among medical students? And secondly, what will it do for access to Medicaid and Medicare?
Thank you, Mr. Pallone. I would say to you that the return to a primary care-based system in this country is essential. It's at the, if you will, it's foundational to building the healthcare system of our future. To get primary care physicians back into a position where they can integrate and coordinate care, lower costs, and increase quality, we must do that. Right now, primary care is in crisis. A lot of that has to do with the dysfunctional payment system. Primary care practices are barely making it in regards to their margins. So what we have to do in terms of the reform measures is, number one, make this viable financially for physicians to choose primary care.
But tell me whether you think this, these proposals that are in our draft discussion will accomplish that. Will we get more medical students to go into primary care, and what will it mean for access to Medicaid and Medicare, specifically with this proposal before us?
Right. So medical students now are opting not to choose primary care because they can see that incomes can be 3 to 5 times higher if they choose subspecialties. So the payment reform will help narrow that gap and disparity so that they choose more to do primary care. The derivative effect of that is that workforce will then be enhanced, access then increases. What we must do in the system is not only cover people, but we've got to have the right types of physicians in the right communities to see them. So it's kind of multifaceted, multi-layered. We've got to fix payment, which will increase workforce. Workforce will enhance access. That's how it's all linked. What it saves America is cost in the long run, increases affordability and access as a derivative.
Do you believe that this discussion draft will accomplish that?
Yes.
Okay.
Yes.
Now let me just ask my Medicaid and DISH question of Dr. Gabo, if I can. Can you talk to us on Medicaid? What will it mean to have Medicaid covering up to 133% of the federal poverty level, having subsidies that help people access health care up to 400%, and to have individuals' response to encourage all else to make sure that their dependents have health insurance? So basically, you know, the increase to the poverty level to eligibility for Medicaid, the subsidy in the health and marketplace, and the individual mandate. That's a lot.
Yes, well, clearly,
1 minute.
Anything that expands coverage, particularly for low-income, vulnerable people, will reduce our $360 million of uninsured care. But as it relates to Medicaid disproportionate share payment, I think the timing is important. We would like to make sure that we see that the patients actually who are eligible get enrolled and that they are covered and that our uninsured costs go down before there's any change in disproportionate share payments. So we applaud your version of the draft bill regarding DISH. We know that many patients who we hope to get enrolled are the most difficult to enroll. For example, the homeless, for whom we did over $100 billion of care last year, the chronically mentally ill, illiteracy. These patients have been difficult to enroll in Medicaid. So I think expanding Medicaid is terrific, but I don't know that immediately it will reduce our need for other coverage. Ultimately, it should, and I think we've seen in Massachusetts that a reduction of DISH at the front end has had a negative effect on the two principal safety net institutions. So I think the expansion of coverage that you are planning will reduce the amount of uninsured care over time, and we need to deal with that then sequentially as regards DISH.
Thank you. Mr. Deal.
Thank you. I'm going to ask for a yes or no answer from a couple of you on this first question. We just heard the preceding panel member, who was chairman of MedPAC, say that he felt that Medicare reimbursements were adequate. And I would ask if you concur with that. Dr. Williamson?
No.
Dr. Ulrich?
No.
Dr. Wright?
Nope.
Dr. Epperly, I'm going to ask you that question in the context of the current reimbursements under Medicare, not counting the bonuses that are proposed in this legislation. Do you consider the current Medicare reimbursements to be adequate?
No, sir, I don't.
Have you, Dr. Epperly, as a result of that inadequacy, seen many of the members of your organization not take Medicare patients?
Yes, sir, I have.
All right. Dr. Williamson, first of all, let me acknowledge that he's the president of my Georgia Medical Association, and I'm pleased to have him here. I made those statements yesterday in your absence as we began these hearings yesterday. Dr. Williamson, let me ask you what you think the impact would be for the public option plan to adopt the Medicare reimbursement plan as its model. How would that impact the delivery of health care under the public option plan, and also as it then migrates, in my opinion, to the private insurance market?
I think it would have a very adverse impact on access for patients and on the delivery of quality medical care. Right now, access for Medicare patients, I think, is really a house of cards. A lot of doctors are there simply by inertia. And surveys that have been done in Georgia amongst practicing physicians show that a large percentage of doctors plan on dropping Medicare in the near future. And I think that that is just basically a train coming down the track. And I think any system that is modeled on that premise is really going to fail in the short run, not the long run.
The doctor-patient relationship has been really the cornerstone of the importance of our healthcare delivery system that makes it work. I would ask you, Dr. Williamson, in light of this draft legislation, in particular the comparative effectiveness portion of it, how do you see that potentially impacting that doctor-patient relationship?
I think it's going to push us farther and farther away from it, which is really, I think, the opposite direction that we need to be going. I have serious concerns that bundling payments is going to drive a wedge between patients and their physicians. I know that in some clinics that we've looked at as examples, that type of environment works, but those are rare, and I think they're different than the general practice of medicine across the country. And they have a different patient population in some cases. I have grave concerns about comparative effectiveness as well. I think this would essentially give the federal government the ability to practice medicine. And I know that's a strong statement, but let me say this. Scientific research is not new. It's always been done, and it's always been the basis of medical learning and medical treatment. But the art of medicine is taking this science, these large studies, and applying it to an individual patient. When you try to treat the individual from the 30,000-foot level, it's very difficult. And I'm afraid that this would drastically diminish our choice of options for our patients. I can tell you that I'm well aware as a neurologist of the importance of the last 20 years in pharmaceutical research. I have a lot of options for my patients now that weren't available before. And some of these things are found quite by accident. and we take them and we apply them, and they may be off-label drugs and that sort of thing. And they may even be therapies that have not been shown to work in large randomized controlled trials that take many years and millions of dollars to accomplish. And if we're limited by that, we're going to have a lot of therapies taken off the table for our patients. And I'll also tell you that I think that it's a bit of a conflict of interest to have the government deciding what is valuable to patients because they're serving as the largest payer. I think that the physician and the patient ought to be able to decide in the context of private contracting what is value and what is appropriate care.
Thank you. Mr. Roberts, you have alluded to the issue with AMP. As you know, earlier this year I introduced an amendment that I think was more appropriately dealing with this federal upper limit for reimbursement of going to 300% of the volume weighted average, and also included a minimum prescribing fee for pharmacists, or dispensing fee, I should say, for pharmacists. Which of those options do you prefer, what I offered earlier this year versus what's in this bill?
Well, I think, Congressman Deal, that the challenge that we have is that we really don't know what this benchmark is. So there have been some changes made in the current version that redefines the benchmark in a way that will make it much better than what it was. But the reality of what you are proposing and having a minimum dispensing fee, I think, is absolutely critical. The challenge that we have is that, the benchmark is just meant to get us to break even on the cost of the product. But the reality is the state set the dispensing fees, and the dispensing fees are all over the place from one state to another. And so unless the federal government takes some action to say, that our costs of dispensing and a small profit are available to the pharmacy, it's going to be very difficult to have pharmacies remain viable and still stay in the Medicaid.
Mr. Chairman, I take that as an endorsement of my approach, and I will yield back.
Thank you. Our Vice Chair, Ms. Capps.
Thank you, Mr. Chairman. And I want to thank again all of the panelists for appearing today. It was a very interesting presentation that each of you made, a lot of linking, which I think is really important for us to have as part of this discussion. Of course, Dr. White, I want to single you out and thank you for being here today to represent the voice of America's nurses, who are so important every day in delivery of health care, but also in understanding what this crisis is all about. I was very pleased to hear that the American Nurses Association has endorsed a public plan option. I also support this option and the one that we are developing in this legislation, and want to hear your perspective a bit more as a nurse on why this is so essential, because it is one of the crucial parts of the choice that people are going to make, whether or not they support this reform legislation. Nurses, I'll ask you to do it within this framework. I often speak about the role that nurses have, not only as providers of health care and delivering service, but we're also patient advocates. And would you talk about maybe the reason you endorsed as ANA the public plan option, and why you feel it is best for patients, and perhaps are encouraging patients to advocate for this as well as the choice, to have this choice be made available?
Thank you, Ms. Capps. I'm happy to answer that question because I do think it's extremely important. The American Nurses Association endorsing the public option plan because, as you said, our role in direct care, we're there 24/7, 24 hours a day, 7 days a week, 365. If depending on how long a patient is in there, we don't like to think it's that long, but we see patients and families and how they're dealing with the catastrophic impact of illness, whether it's an episodic, a single acute that affects the patient and their family, or whether it's a long-term kind of chronic condition that includes many admissions or many returns, and not being able to have a choice of insurance, I think, is key. And unfortunately, we've seen employer plans rising, the costs of those to patients rising greater than wages over the last several years, and so patients are looking for other ways of paying for their health care insurance, and sometimes those plans may not be exactly what they think they are, or they may have surprises. So certainly a public plan that includes some type of defined or essential benefit package that the patient, the family, could be sure will be there when they need it, I think is extremely important.
Let me follow this by another aspect of our reform legislation. One of the ways, Dr. Epperling mentioned this, but he wasn't the only one on the panel, which was interesting, who is stressing now primary care as one of the ways we can lower health costs, and the ways that he discussed on how we can improve our primary care workforce. But there are many advanced practice nurses, nurse practitioners, and others who can and do serve as primary care providers. And this bill ensures that nurse practitioners can be the lead providers in medical home models and increases reimbursements, for example, for certified nurse midwives. Can you discuss this a little bit? You mentioned one bill that I've co-authored on nurse-managed clinics, but that's not the only avenue. And you might mention a few others for the record.
Absolutely. obviously the nurse-managed clinics is an extremely important way for many vulnerable populations, inner-city rural areas that get primary care and other other follow-up care in those areas. And as far as nurse practitioners, as our advanced practice nurses functioning within the primary care medical home and being able to lead those teams. We've seen in the demonstration projects throughout the country that nurse practitioners have been paneled. They do function to their scope of practice in the different states and the different demonstration projects, and have been able to lead their panel of patients and provide that primary care. I think it's extremely important when we're talking about the shortage of primary care that all providers be able to be used to the fullest extent of their scope that they can provide the care.
Thank you very much. I'll yield back.
The gentleman from Indiana, Mr. Boyer.
The challenge we have with a panel this large is to try to get our questions in. So if you can take out a pen and pad, I'm going to rip through some questions. Not all, won't apply to all of you. First, I'm going to go to Mr. Yarwood. When you stated that provisions in the draft bill would cut Medicare reimbursement rates to skilled nursing facilities by $1.05 billion in FY 2010 alone, and ultimately $18 billion from skilled nursing care over 10 years, I'd like to know whether you've calculated the number of jobs that would be lost due to these cuts. Next question I have would go to Dr. Ulrich. The draft bill provides that physicians who treat both Medicare and the public plan patients would receive Medicare plus 5% for treating their public plan, really the government plan, patients for the first 3 years. What is the, quote, magic number, end quote, regarding the percent of Medicare that it would take to keep you whole? Is it Medicare plus 10, plus 12, plus 13, plus 14? The other question I have for Blue Cross Blue Shield, what are the advantages that the government plan would have over the private insurers? What about state premium taxes, state solvency regulations, state benefit mandate requirements? And the last question I have, I'm going to go right down the line with all of you. Medical liability reform, should it be medical liability reform that restricts excess compensatory awards, limits on punitive damages, and attorney fees, should this be part of the public plan option? Let's go right down the line. Dr. Epperly?
Yes, we believe that.
Dr. Williamson?
Absolutely.
Dr. Ulrich?
Yes.
Dr. Wright?
Yes.
Dr. White?
Yes. Yes.
Yes.
We have FTCA coverage, so I can't really comment.
All right, one equivocator.
Yes.
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 All right, all but one, except Mr. Hawkins, testified in the affirmative that it should be included. The other is, would everyone on this panel agree that individual liberty is a cornerstone of our society as an unalienable right? Would everyone on this panel agree? Okay. Mr. Hawkins, you in? He's in. All right. Awesome. Now, an individual right. If in this scheme we're moving people into the government plan, what about an individual's right to contract with a physician of their choice? Should an individual in America have the right to contract with an individual doctor of their choice? Yes or no? Dr. Epperly?
Yes.
Oh, let me go down. Without penalty from their government. Dr. Epperly?
Yes.
Dr.
Yes.
Williamson?
Yes.
Yes.
Individual provider, yes.
Atta girl.
Yes.
With their own money, yes.
Attaboy.
Yes.
Oh, we're on a roll. Now, does everyone agree that in the capital economic system that we have, even though we may have a public option plan, that the marketplace should be able to create some type of an instrument that would be a supplement? a potential medical insurance supplement plan. Should that be some type of an option that the marketplace could create? Dr. Epperly?
Yes.
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 No.
Well,
I'm not sure.
okay. Dr. White's an unsure.
No.
A no.
I'm not sure I understand.
I'm not sure.
I'm not sure I do either.
Two, I'm not.
I'm a number 3, not sure.
Well, we're hoping that there is no public plan.
Pardon?
We're hopeful there will be no public plan in the program. Yeah.
All right. But if there's a public plan, should individuals in the marketplace have an option, be able to create supplemental coverage?
Yes.
Yes?
Yes, like Medicare today.
All right, thank you. Now I'll rest and allow those individuals to answer the questions that I'd asked.
The answer is Medicare plus 100, and I can expound as to why if you'd prefer. I think in my testimony I cited the fact that we currently in Wisconsin, from the private sector, get anywhere from 180 to 280% of Medicare in payment. Medicine is changing, and this is what's really interesting, is that we've gone from kind of being a cottage industry to now much more high-tech. Our costs are very different than what Medicare allocates to us now. We now employ, for example, systems engineers. Why? Trying to understand efficiency of workflow. We also, in our clinic, and others as well, employ many people in information technology. We've developed our own electronic medical record. We have close to 350 employees now, software engineers, et cetera. Our cost structure has shifted dramatically from what the traditional concept of what medical practice is, a nurse practitioner, physician, a nurse, a technician, et cetera. And so the costs keep changing. The other thing I would ask this committee to keep in mind is that medicine as an entity is an ever-evolving one, in the sense that we've come from guessing at what causes disease
Ulrich,
a couple of
could
centuries
you,
ago. Yes.
We're way over time. Could
Okay.
you wrap up your response, please?
I will just stop there if my initial answer satisfied you.
Mr. Yarwood, do you have an answer? 30,000 jobs.
30,000 jobs?
Over 10 years, yes.
Would be lost.
Yes.
Thank you. The gentleman's time has expired. The chair now recognizes Ms. Castor for 5 minutes.
Thank you, Madam Chair, very much. And I'd like to return to the workforce issues. This bill rightfully targets workforce incentives because we must bolster the primary care workforce especially. 50 years ago, half of the doctors in America practiced family medicine and pediatrics. Today, 63% are specialists and only 37% are family doctors. And it's those family doctors and the nurses on the front lines and the pediatricians that really help us contain costs over time. I do not know what I would do if I did not have the ability to call the nurse in my daughter's pediatrician's office and ask a question. And they've had a consistent medical home over time, and yet millions of American families do not have that type of medical home and relationship with their primary care providers. So I think our bill does take important steps to bolster primary care workforce, but one place that I think it falls short, and I'd be very interested in your opinions, is that we are not increasing the residency slots for our medical school graduates, these doctors in training. The discussion draft provides a redistribution of unused residency slots to emphasize primary care, which is a good first step. Because we're going to hopefully send them to community health centers and other hospitals in need and other communities in need. But we've got to enact the second step, the complementary step, to even out the residency slots because, for example, in my home state of Florida, the 4th largest state in the country, we rank 44th in the number of residency slots. And most folks do not understand that those slots are governed by an old, outdated, arbitrary formula that assigned a distribution many years ago and has not changed, even though the population of the country has shifted. So I'd like to know, do you agree? Dr. Epperly, you might be the one most in tune, but I think many of you would have an opinion on that. Do you agree we need to alter the residency in toto. And then are there sections in the bill, the sections in the bill related to scholarships and loan repayments, are they adequate? Are we doing enough?
Yes, ma'am. Can I expand for just a second?
Yes.
In my day job, I'm a residency program director of family medicine program in Boise, Idaho. And you're right on. In fact, the workforce numbers are about 70-30 subspecialists to generalists. We must increase residency training, especially for primary care. Again, what are we trying to build? What system are we after? We think there should be some regulation of what kind of physicians medical schools are producing. It needs to meet community needs, and so we're in agreement with some sort of workforce policy center to kind of take a look at this and what it is we're trying to accomplish. Totally agree with you in terms of scholarships and loan repayment. Scholarships on the front end will be more effective than loan repayment on the back end because it helps shape the types of physicians you're trying to train.
Anyone else want to comment quickly? Okay. Then I'll move on. Ms. Fox, thank you so much. It's great to hear that Blue Cross is supportive of health care reform. What I wanted to share with you, I had a great meeting last week with the Florida CEO, President and CEO of Blue Cross, and you all are a very important provider in the state of Florida. You have about 32% of the market share in the state of Florida. Let's see, I wrote it down, 4 million Floridians are enrolled in Blue Cross and depend on you all every day. It was interesting that the CEO from Florida had a slightly different take and spoke much more favorably of the public option because while Blue Cross in Florida has 30% of the market share and over 4 million folks enrolled, you know, in Florida we have 5.8 million people who do not have access to health insurance because it is so expensive. And I think that in the discussion we had, he just saw it as an opportunity, that you all are so effective that you wouldn't have any trouble competing against a startup public option. And I thought we had a great discussion and exchange, and I was heartened to hear that maybe it's not, maybe while Big Blue Cross has a certain position, the folks on the ground in my state are not daunted by the challenge ahead.
Well, I would respond that I think people are looking at, can you create a level playing field? And I think it's very difficult to imagine how you can. And when I look at the House draft bill, I just see huge advantages for the government plan, ranging from big advantages in the payment levels to lawsuits to covering the government plan would cover a lot fewer benefits than private plans would be required to do. There's just a long list. For example, if the government plan didn't estimate their premiums correctly, would the government step in and subsidize
But where do these almost 6 million residents of my state go now? How do they, we can't afford, America can't pay for all of them to go into subsidized Medicaid. We've got to provide a level playing field and a real opportunity for them to access affordable care.
Well, we agree. We need to cover everyone, and we're recommending covering everyone in poverty under Medicaid, and then above that, having subsidies, as you do in your bill, for private insurance to help people afford coverage. We think that is absolutely critical. And I've been doing healthcare issues for over 25 years, and it used to be that everybody believed that if you have individual mandate, employer mandate, alliances, insurance reforms, that really would cover everyone. It's only been the past year people have talked about a public plan. We think it's totally unnecessary and very problematic.
Thank you. The gentlelady's time has expired. I now recognize Mr. Burgess for 5 minutes.
Thank you, Madam Chairman. And Ms. Fox, let's continue on that, and maybe if I could, I think Mr. Bouyer was asking a question, or you were answering a question when time ran out, and maybe we could just get the answer to the question that Mr. Bouyer posed about the advantages that a public plan rather would have over private insurance in premium taxes, state solvency regulations, and state benefit mandates.
Yes, I mean, private plans have to pay a wide range of premium taxes, assessments, federal taxes. The government would be exempt from that. We've actually prepared a little chart that we'd love to submit that actually walks through what are the rules private plans have to abide by.
If you'll suspend for a moment, I'd ask unanimous consent that that chart be made available to the members and made part of the record.
And raises questions, would the public plan abide by that? And when we look at the draft bill, we see just a huge unlevel playing field where the government would have so many advantages that you could see why people will estimate that millions of people will leave private coverage that they like today and go into the public plan.
Okay, great. I appreciate that answer very much. Dr. Ehrlich, let me just address you for a second. And I really appreciate, well, I appreciate all of you being here. I know that many of you are taking time off of your private individual practices, and it's with great expense and inconvenience to your families, and we've had a long day and appreciate your willingness to be part of the panel here. The physician group practice demonstration project that you referenced at your clinic, I'm somewhat familiar with that. I think that does hold a lot of promise. In fact, you may have heard me question Mr. Hackbarth from the MedPAC about the feasibility of using the Federal Tort Claims Act for Medicare providers under a physician group practice model, under the accountable care model. If you comport with all of the requirements, disease management, care coordination, the IT, the e-prescribing, if you do all of those things, getting some relief from liability under the Federal Tort Claims Act. Do you think that's is that a reasonable thing to look at?
Absolutely. And
thank you, and appreciate your brevity. Let me ask you this, since we're in agreement. Yeah, one of the things about the physician group practice demonstration project was you were going to actually benefit financially by doing things better, faster, cheaper, smarter. And in fact, there's some great lessons for us that have come out of those management techniques. But there's a barrier to entry, and do you think the bar to that has been set too high? You've got to make a lot of initial investment when you get into that, and then your return for your doctors, for the people in your practice, is a little slow in coming. Is that not correct?
Dr. Burgess, you show keen insight here into this, and if I can just take a second to explain this. As part of the group demonstration project, what we're finding is that it's not just trying to strive for quality outcomes. There are operational changes that you need to make in how you deliver care. For example, we have consolidated all of our anticoagulation patients into one entity. Rather than being in each physician's practice, we now share that coordinated care under one entity. And what we found is that our capacity to have bleeding times, for example, are much better, be within the therapeutic range. We also are consolidating care of congestive heart failure rather than being in a particular individual physician's office, whether it be a cardiologist or a primary care physician, into a congestive heart failure clinic, where physicians craft the criteria we want. Our nurses watch those. We are proactive in working with the patients. The problem with doing all that is that no one pays us, to undertake those operational changes at first. What we're hoping, and why we partnered with the federal government through the CMS PGP project, is that we're trying to prove that, yes, by undertaking these, ultimately there are cost savings. Lastly, I would just make the point that we're just beginning the process of understanding the cost of care in chronic illness over time. We understand what the costs are to provide care at an individual visit, but not over time yet.
Yeah, one of the things that concerns me about our approach to things, and what little I know of the great successes you've shown, for example, like bringing a hospitalized CHF patient back to the doctor's office within 5 days, not just you make an appointment in 2 weeks, you get that patient back to the office in 5 days, and you really reduce the rehospitalization rate significantly. And yet you've got CMS now writing a rule that says, well, if that's the case and you can do that, we're just going to pay for one hospitalization every 30 days, and that'll cut our costs down. It's an absolutely backward way of looking at what the data that you all are generating, and instead of building on your successes, in fact, we're going to make things punitive then for Dr. Williamson in Georgia, who may have an entirely different type of practice.
Correct.
And again, that's one of the things that concerns me about this. Do you have a concept? You mentioned about the rate of reimbursement on the Medicare side. What would that multiplier have to be in your accountable care organization or physician group practice? What would that Medicare multiplier have to be in a public plan?
We would say Medicare plus 100.
Medicare plus 100%?
Yes.
So double what the Medicare rates are?
Yep.
That's a fairly significant.
That is significant, but it's also a realistic significantly high.
And do you have data to back that up that you could share with the committee?
I would be happy to provide information to you in written form Relative to that, yes.
That'd be tremendous. And Dr. Williamson, in words of one syllable, we heard Glenn Heckbarth say that no doctors are not seeing Medicare patients now because of the reimbursement rate. Is that your sense? Do you think doctors are restricting their practice because of the reimbursement rates in Medicare?
Yes.
Thank you.
Thank you. The gentleman's time has expired. I now recognize myself for 5 minutes. And let me just welcome everyone. It's great to have such a diverse panel of witnesses here, and we thank you for all of the good work that all of you have been doing in a dysfunctional system that really doesn't always give you the kind of support that you need. And I want to particularly welcome Dr. Epperly, President of the American Academy of Family Physicians. And I want to direct my first question to you, Dr. Epperly. In meetings, for example, with the Tri-Caucus, we're on record as supporting a public plan, and I do support a public plan, but also a public plan that is linked to Medicare. I have raised concerns about that in our meetings, and I'd like you to elaborate on your concerns about linking the public plan to Medicare.
Yes, ma'am. Thank you. First, we're definitely in support of a public plan option, but we do have a couple caveats. One of them is linked to Medicare, just as you're saying. We recognize there's going to be a huge infrastructure cost in getting this thing up and running. So our position is that it can be the Medicare rate for the first 2 years, but with a date certain then to elevate that. More of just Medicare rates won't cut it for the physicians across America. It's already a problem.
Right.
So, but we recognize that there's going to be a transition period. We recognize that flexibility. So what we would say is, yes, we're in favor of a public plan. Medicare rates could be what it would be aimed at for the first 2 years, but by date certain, that has to elevate.
Thank you. And I guess I can't ask everyone this question. So Dr. Epperly, Dr. Gabow, and Mr. Hawkins, you've heard reference to bundling of payments by Mr. Hackbar of MedPAC, and I wanted to know if you are in support of the proposal to bundle payments to providers. Dr. Epperly?
Yes, ma'am. We're in favor of bundling in terms of a team approach. We do have concerns that we'd want to make sure that primary care and the patient-centered medical home as a very important part of that bundling was not denigrated nor belittled into its importance. For instance, with the heart failure example, we're talking about heart failure patients and readmissions. Let's prevent it from in the first place. So with a bundling model which looks at already this has occurred, it's in the hospital, how do we pay for this? Why don't we take a better approach and look at what it takes to prevent that in the first place? So therefore, the patient-centered medical home primary care is critical in that. Bundling could be a very interesting option if the primary care physician has reincorporated that into that in a big way.
Dr. Gabow?
As an integrated system that employs physicians, we favor moving away from fee-for-service to a more global payment. And we would favor the ultimate bundle, capitation, and think that capitation or more global bundling would have less administrative cost than if you bundle small things. So I would encourage it to be global, but we favor it given an big integrated system.
Congressman or Mr.
Would it affect,
Madam Chair,
would it affect community health centers?
Really, there are some important points to make here. On today's panel, we're very fortunate to be joined by Dr. Epperly, who runs a family medicine residency program, Dr. Ulrich, who runs the Marshfield Clinic, and Dr. Gabow, who runs Denver Health. Unique, and especially with the last two, fully integrated healthcare systems. What may not be known generally, but should be, is that all three are community health centers, or have community health centers embedded in them. As such, two examples, Denver Health and Marshfield Clinic, are good examples of integrated health systems that include community health centers. But I'm sure, as Dr. Gabow and Dr. Ulrich would agree, the primary care component, the very issue that Dr. Epperly expressed appropriate concern over, is identified and I'm not going to say separate, but it is able to function on a sort of co-equal basis with the specialty and inpatient care components of their institutions. To the extent that that's done, I think that's what Dr. Epperly was relating to when he said primary care needs to be recognized and appropriately integrated. We would agree. The notion of integrated care systems, accountable care organizations, and the like, and rewarding results is something that we all absolutely support. What should not be lost, however, in the integration of care, the vertical integration of care across primary, secondary, tertiary care, is the small ambulatory care practice, be it independent practice, private practice, physicians, health centers, or other forms of ambulatory care within the context of a large, multi-level institution like Denver Health. And I'm sure Dr. Gabot would agree with that.
Thank you. To be a good example, my time is up, but I want to also, without objection, accept the chart from Blue Cross Blue Shield into the record that was brought to us by Dr. Burgess. Chair now recognizes Dr. Ginry for 5 minutes.
Madam Chair, thank you so much. I want to direct my first questioning to my colleague from Georgia, Gainesville, Georgia, and the president of the Medical Association of Georgia. Glad to see you, Dr. Williamson. And I have a series of questions that I would like to ask you. First off, do you support a government-run plan?
No, the Medical Association of Georgia does not support a public option or a government-run plan, in addition to the public plans that already exist, Medicare and Medicaid.
Right. We're talking about the government option plan that would be competing with the private insurance plans.
We do not support a public option.
What would a government-run health plan that I just described do to your ability and those of your colleagues to treat your patients? What do you fear the most about that type of a government-run option?
My biggest concern is that it, like Medicare, will become the only option. And I think over time, I think the plan as it's set up in the discussion draft already has the framework for that, for basically all private plans to have to conform to certain rules over time. And my fear, and I think it's a very real concern, is that over time other plans will disappear and the public option will become the only option, and we'll be left with a single payer system, which I think if you look at what's happened across the planet, single payer systems basically save money by rationing care, and I see that as an inevitable consequence of the creation of a public option, no matter how benign it looks at first glance.
Well, that was going to be my next question. You pretty much answered it. My question would be, Dr. Williamson, do you support a government-run health care system with the ability to ration care based on cost?
I absolutely do not support that. I think that care decisions should be made on an individual basis when the patient sits down in the physician's office, and I don't think that the government can substitute for the training that a physician has and the opportunity that a physician has to look the patient in the eye and decide what that patient needs.
Let's see. I'm going to skip over number 4. My fourth actually. We have heard testimony in this committee recently regarding the Massachusetts health care system and the fact that those with public health insurance in the state are twice as likely as those who choose private health insurance to be turned away from a desired physician. As a physician, practicing physician, what are your thoughts on the reasons behind that kind of disparity in access between a public and a private insurance plan?
Well, public plans in general, and I'm speaking in general now, are associated with quite a lot of paperwork. They're associated with the hand of government, and right now in Georgia we're looking at these recovery auditor contractors that are moving across the nation and coming back and recouping money, saying that you coded something wrong 20 years ago or 10 years ago, and coming after those dollars. These sorts of things that the federal government has the power to do makes dealing with them as a payer a very daunting prospect. And traditionally, government payers have been at the bottom of the barrel in terms of covering costs. And so physicians feel like they can't deliver to patients what they've been trained to do. And the downsides associated with the government as a payer are daunting. And, you know, I recently had the opportunity to go to the AMA, and one of my colleagues from Massachusetts stood and spoke loudly in support of a national public option, but I believe that the folks from Massachusetts probably want a public option nationally so they don't have to pay for their own anymore.
Well, Doctor, I appreciate that response, and I absolutely, the reason I ask you the question, because what we're talking about here is something very, very similar to this Massachusetts model. And we have even heard suggestions from the majority that it may be that physicians who are treating people within this exchange would absolutely have to accept the public option plan, or they would be ruled ineligible to participate in Medicare or Medicaid. So they would have their arm twisted behind their back and have no choice, which is pretty frightening. I've got just a little bit of time left, and I wanted to go to Dr. Ehrlich and also Dr. Gabot, if we have a chance, time permits, Madam Chair. I hope you'll let me get this in. If health reform were to include a requirement that all Americans purchase health insurance, do you think that hospitals would need continued federal funding to offset cases of uncompensated or charity care, and why? And basically, I'm talking about DSH hospitals and the suggestion that we're going to save money by eliminating all DSH payments when we pass this bill.
Well, my sense is the answer to that is yes, you would still need to have some supplemental dollars rolling in, simply because the reality is that there still are things as bad debt, you know, people who need care get it and then can't pay for it because of competing priorities of their own pocketbook. And plus the fact that, you know, we really haven't gotten to the point of having fair practice expense accountability within the remunerative system yet. And that is absolutely critical to any kind of a public plan. If we're going to go that way, then we have to have fair practice expenses covered before we can go forward.
That would be a pretty painful pay-for your
That is correct.
Dr. Gabot.
My understanding, Congressman, is that this bill does not cut disproportionate share payments, and I think that that will be necessary to be sustained, at least in the foreseeable future, because we know that many of the patients that we serve, the homeless, the chronically mentally ill, are traditionally difficult to enroll. And so I think if we got to full coverage, certainly we may be able to decrease it, but I doubt that it will ever go away. So we support the preservation of DSH as outlined in the draft bill.
You support the elimination of DSH payments? Is that what you said?
We support the maintenance of DSH payments.
Oh, absolutely. Yes. As I expected you would, Dr. Gabot, and as Dr. Ehrlich, and hospitals all across the 11th Congressional District of Georgia support the continuation of those DSH payments. Thank you for your patience, Madam Chair.
Thank you.
I yield back. Thank you.
The Chair now recognizes Congresswoman Baldwin for 5 minutes.
Thank you, Madam Chairwoman. I want to welcome a fellow Wisconsinite, Dr. Ulrich. Pleased to have you on the panel. I wanted to probe into an area. I stepped out for a little while, so I don't know if anyone else has raised this, but in your testimony on page 7, you talk a little bit about care issues at the end of life and make some recommendations. And it's one of those very challenging topics, because we certainly hear from much research that much of our healthcare dollar goes to treat people at that stage of their lives. But that's one thing. I mean, much more disturbingly, that often doesn't align with the wishes of the person being treated. Could you elaborate a little bit more about both your recommendations to this committee in that arena, but also the practices at the Marshfield Clinic, what you have implemented in this regard?
Yes, thank you, Congresswoman. I appreciate the question. At Marshfield Clinic, we do have, in conjunction with St. Joseph's Hospital, who's our hospital partner, developed palliative care. We have a palliative care fellowship, et cetera, where we train young physicians who are interested in that. We work with families, the patient, obviously, et cetera. Really try to do two things. One, there's a humanistic process that occurs under palliative care, and that's taking care of people in a comfortable surrounding in their last few weeks or days of life. And that really is a throwback, if you will, to the way medicine used to be practiced before we were very fancy with technology, et cetera. And it's not something that we should ever forget. It's something that we need to continue. So we are committed to doing that and will. And I think most medical organizations throughout the country would be in synchrony with that kind of concept. The question you raise about the cost of care at the end of life is obviously an important one. And if you think about the cost of medical care in our country, there are really two main things we need to understand. One, as you point out, the costs escalate rather dramatically as life is ebbing away from us because it's an emotional decision for families and patients to keep mom or dad or grandma or grandpa alive for a little while longer, et cetera. It's very difficult for families to say it's time to say goodbye to someone. So we continue then to provide medical care under those very difficult circumstances. There's a cost to providing that care. The other thing that I would like the subcommittee to understand is that not all costs within the system are the same. So that we know from the Commonwealth Fund, for example, that really it's only about 20% of patients that are costing about 75 to 80% of care in this country. So that if we can manage these chronic illnesses, and in particular patients who have more than one or two chronic illnesses concomitantly, that's where the cost savings will come as we get better in managing folks with complicated chronic illnesses who concurrently are suffering from several of them at the same time.
Your testimony specifically points to things that we could do earlier in life to talk about having people think about advance directives or other documents. I would offer you to elaborate on that, but also I see some other nodding heads. If I would open this up to any of the panelists who would like to make a contribution on this point.
Thank you. What Dr. Ulrich just described is the value of primary care. It's having that relationship of trust with people over time in which you can have that type of dialogue. And I would say that those sorts of decisions are so important, so critical to the family as a whole, and many of those decisions can take place outside of a hospital in terms of where those final days and weeks are. In fact, I would submit that most people would like to have a very dignified death in the place where they can be surrounded by most of their loved ones. And so, again, we return right squarely back to what primary care brings to the system. It's what Dr. Ulrich said used to be part of medicine that's kind of gone now. We need to recreate that kind of system. It's in that system that savings are made, quality goes up, cost goes down.
Please, Dr. Wright.
Yes, I just would like to agree that what needs to take place and is often missing is the conversation, which begins with the relationship. So I completely agree and would support recognition of the value of the cognitive services. Not to say that folks who do procedures for a living are not thinking them, they certainly are, but the importance, I've seen it over and over in my practice, that while someone does indeed benefit from a procedure, what's wrapped around that procedure, the informed consent process, the education about the disease process, and right now the aftercare to try to prevent that from ever happening again is incredibly valuable to that individual and that family and our economy at this point.
Dr. White, did you have a comment?
Yes, I'd just like to add that I think, as Congresswoman Capps had mentioned earlier, that the patient advocate role that nurses provide is absolutely important in this. And I think the emphasis on primary care medical home, nurse practitioners being involved in that who have the skills for those conversations, discussions, and the relationships, I think would be an important consideration for it all.
Thank you. I would like to briefly add, I think that resources spent on time with the doctor saves money in the long run. If you look at the percentage of medical expenditures, physicians' services constitute a small fraction of that. By concentrating on that, whether it be for primary care or for a specialist, you're going to save money in other areas, whether this is the end of life, very sick patients. So funds, resources that are concentrated on giving the patient or the patient's family face time with their doctor is going to save you lots of money across the system.
Thank you. The gentlelady's time has expired, and I now recognize Congresswoman Blackburn for 5 minutes.
Madam Chairman, and thank you to all of you. I want to do a yes and no and show of hands to get where you all are on some issues. And by the way, thank you for your patience with us today. As you know, we have another hearing that's been going on upstairs. Okay, show of hands. How many of you favor a single-payer system? Okay, nobody on the panel favors a single-payer system. Okay, how many of you favor a strategy, putting in place a strategy that would eventually move us to a single-payer system? So nobody favors doing that. That's really interesting because there are some of us that fully believe that this bill that is before us, whether it is the House version, the Senate version, or the Kennedy plan, would move us to a single-payer system. And we make that determination based on experience that we've had from pilot projects and from programs that have taken place in the states, my state of Tennessee being one of those. Okay, how many of you favor having government-controlled comparative research? Nobody favors government-controlled comparative research, okay? How many of you... Okay, we've got some takers on that one. All right, just show of hands. The comparative research board that they are talking about having, that this bill would put in place, how many of you want to see that? Okay, so got Epperly, Ulrich, Wright, White, and Gabal. Okay. Dr. Hankins, all righty. And then how many of you favor having that comparative research board make medical decisions for patients? Nobody. Okay. All righty. Dr. Epperly, if I could come, you know, makes it kind of a head scratcher to me, and I appreciate having your views on this because we know that the Comparative Research Results Board would end up making a lot of the medical decisions for patients, and it would move that away from the doctor-patient relationship. I wanted to ask you, you had mentioned in your testimony that you felt that a public plan would be actuarially sound. What I'd like for you to do is cite for me the research upon which you base that assessment and that decision. How did you arrive at that?
Yeah, I would say that I'm not aware of anything I said that it would be actuarially sound.
Well, I think that's a statement in your testimony.
What I will say as you look that up, though, is that we believe that expanding coverage to people and giving them choice is a sound decision for America in regards to helping people get health care coverage. We are in agreement with that. As it presently stands, this would have to be at an enhanced rate above Medicare. That's why we say that, you know, if the model is Medicare, that's not going to work. But at anything that starts to promote primary care as being a solution to that, that will work. And that's
okay, let me interrupt you at that then. You say that it would be at an enhanced model above the rate of Medicare. So in other words, it's going to cost more.
Yes, but the...
Okay, now yesterday, if I may interrupt you again, Secretary Sebelius said yesterday that this would be deficit neutral. So I'm trying to figure out, and I asked her yesterday how she could say it was deficit neutral. We've not had one witness out of all the hearings we've done that has said they felt like this would be deficit neutral or would be a money saver. Everybody has said it's going to cost more.
I would say that it would be beyond deficit neutral in a positive way, because where the savings will come from the system is in regards to reduced hospitalizations, reduced readmissions, more
okay,
efficient.
If I may interrupt you again, do you have any kind of model that shows that actually happens? Because you can look at TennCare in Tennessee, you can look at Massachusetts, and you can see that that does not happen.
Yes, Community Care of North Carolina proved that. Other international studies have proven that as well. That's why when we talk about the value of primary care, we're saying that there's system savings from across the existing system that will save the entire system money.
Okay. All right, but I can tell you that in Tennessee we found out that did not happen. And so I appreciate your input. Dr. Williamson, I've got 15 seconds left. Medicare patients, senior citizens, are just up in arms. They see that their care is going to be diminished somewhat, that savings from Medicare are going to go to pay for care for younger enrollees in this public plan. my seniors that are coming to me and saying, we are scared to death, what do I say to them? What is Medicare going to look like after this public plan goes in place?
I don't see anything in the draft, in the discussion draft, that gives me hope that we're moving in the right direction in terms of payment. I think that private contracting and empowering patients to buy their own health care, I don't think we should ever take away a patient's right to pay for their own health care. And if we do that, we're committing a colossal mistake.
Okay, thank you. I yield back.
Thank you. The chair now recognizes Congresswoman Harman for 5 minutes.
I thank you, Dr. Christensen, and point out that our committee benefits a lot from the fact that many members are medical doctors and nurses and have extensive medical backgrounds. I hope the panel is impressed that we actually, some of us, others here, know a great deal about this. In my case, I don't have either of those, but I am the daughter of a general practitioner who actually made house calls to 3 generations of patients before he retired in Los Angeles, and I am the sister of an oncologist, a hematologist, who was the head of that practice at Kaiser in San Rafael, California, before he semi-retired. He's younger than I am, so go figure. But he did win the Healer of the Year award in Marin County for his compassionate treatment of patients. So I love listening to a bunch of docs and experts who put that on the front burner. I come from Los Angeles County, as you just heard. We are extremely concerned, if not panicked, about the president's proposed cuts in dish payments. Listening to this panel and listening to you, is it Dr. Gabot or yes? And reading your excellent testimony, I think your bottom line is you don't want cuts on the front end. You want to see how all this works and phase in cuts later once the efficiencies take hold. Is that what you are saying?
That's correct.
Thank you. And on this point, Madam Chair, I would like permission to put a letter in the record from the Board of Supervisors of the County of Los Angeles.
Without objection, it'll be admitted to the record.
Thank you. Well, I would just like to invite the panel on this subject to address, and starting with you, Dr. Gabot, and it seems like you may have a bit of laryngitis, am I right?
Congresswoman, I have a chronic voice problem.
Oh, my goodness.
Called spastic dysphonia, and the treatment for it is Botox, but it doesn't do anything for my wrinkles.
As my kids would say, I think that's more information than we need. But I appreciate this. I hope I'm not stressing you, but I would really like the record to be more complete on this subject because I think it is an urgent subject for at least our large metropolitan areas, and one this committee has to take very seriously. And based on the comments I heard from the minority side, I think everyone here generally agrees about this. Yes.
Congresswoman, I think all of the safety net institutions would be very concerned if disproportionate share funding were cut at the front end of this process. We rely heavily on disproportionate share funding to cover not only our uninsured patients, but also the gap between what Medicaid pays us and our costs. So I think that timing on this issue is really critical. And as I said earlier, I think what we've learned from the expansions in the past of Medicaid and S-CHIP is that it takes a long time to enroll certain highly vulnerable populations. They're vulnerable in so many ways that enrollment is not an easy process. So it's going to take a period of time to really get to full coverage, even with this bill. So I don't think we can cut dish at the front.
I realize I only have 48 seconds left, so let me just expand the question in case anyone else wants to answer it as well. one of my personal issues, since I focus on Homeland Security issues generally, is surge capacity in our hospitals in the event of a terror attack or a large natural disaster. And so my question is, what is the relationship between the ability of our level 1 trauma centers, which are located in many of our DISH hospitals? What is the relationship between the ability of our level 1 trauma centers to be available in the event of a terror attack or a natural disaster and the proposed cuts in DISH?
Congresswoman, I think you're right that these are related in that many of the trauma centers are at the disproportionate share hospitals, and also many of the pre-hospital care services and burn units, so that much that you would need in disaster are located in these safety net institutions. So they need to be preserved, and you can't destabilize them financially at the beginning of the process and still preserve those critical resources.
Thank you very much.
Thank you. The chair now recognizes Mr. Pitts for 5 minutes.
Thank you, Madam Chairman. Dr. Ulrich, if a large number of private payer patients were to shift into the public plan, and the public plan is paid based on Medicare rates, what would be the effect on your ability to continue to offer the same level of services that you provide today?
Well, it would be impacted extremely negatively and probably fairly rapidly. It would be beyond my capacity to give you an exact time frame, but it would be disastrous, I think, is a fair word to use.
Now, are you treating a large number of Medicare or Medicaid eligible patients in your part of Wisconsin?
Absolutely. If I can enlarge on that just a second, there already is a problem as you're describing. In certain parts of the service area that we provide, we comprise about 33% of the physicians. We are caring, however, for 70% of what we call fixed payer, which is Medicare and Medicaid patients. Why? Because other providers are not choosing to take care of those patients. So this is already happening. This is
so how are you surviving now if you...
Well, you know, we try to watch our costs as closely as we can. I've found it necessary to try to branch into ancillary revenue streams, try to sell the electronic medical record. We do food safety with Cargill, with Hormel, et cetera, because I'm not confident that just providing health care is going to be a way to sustain our organization.
Dr. Williamson, each year fewer and fewer physicians are willing to accept Medicare and Medicaid patients. From your perspective as a practicing physician, could you tell us why you think this is?
I think, as has been said, it's becoming more and more impractical to do that. I think inertia plays a large role here. Doctors have done it for a long time. It's becoming less and less practical because the Medicare and the Medicaid payment systems have not kept pace with the cost of providing care. And physicians want to keep taking care of these patients. We want to keep doing that. And so what you're seeing across the nation are doctors basically doing the very best they can to control costs and keep functioning in this environment. But as I said, it's a house of cards. Some doctors are retiring early. They're getting out of medicine. They're going into other ancillary revenue streams because these payment systems simply are not adequate to cover the cost of providing care. And moving more patients onto those types of payment schedules is going to adversely impact everybody's health care in this country, not just those patients that are enrolled in the public option.
Now, if we allowed more people to purchase health care services with untaxed dollars instead of relying so heavily on third-party payers for routine health care services, do you think that we could solve many of our problems faced today by consumers or providers of health care services?
Congressman, I think you just hit the nail on the head. Right now, what we're trying to do is solve a problem for uninsured patients. That's what all this is about. We wouldn't be sitting here if we weren't dealing with this issue. I think that by making it feasible for every person to own and control their own insurance policy is the way to solve this problem. And I know that we can do that with the tax system, with tax credits, tax subsidies. We can put the control back into the hands of the patients so that the government doesn't have to orchestrate this massive machine that we're looking at right now that's going to not attend adequately to the needs of the individual patient. I believe by restructuring the tax system, we can take care of the uninsured patients, and we can solve this problem without putting private insurance companies out of business and taking away the ability of individuals to purchase their own health care.
Dr. Wright, if you could respond. Polling has suggested that over 95% of the American people support the right to know the price of health care services before they go in for treatment. What do you view as the major barriers to the American people getting the price and quality information that they want and they need?
I think there has just not been enough transparency in the pricing structures. It's Byzantine at the very least. It's difficult to figure out even within a practice. Often most of us have no idea what an individual patient is paying for a service. So I think the system would clearly benefit from additional transparency.
And how would the patients, the providers, the taxpayers benefit by public disclosure of price and risk-adjusted quality?
Well, I think it lends to it's one component of their decision-making process. I would not uncouple pricing information from quality information, because cheap care may not necessarily be the best care. On the other hand, the best care can be less expensive than we're delivering it now.
What about the agency that reports price and risk-adjusted quality information to be completely separate from Department of Health and Human Services? Do you see any conflicts of interest with HHS reporting on their own programs?
No, I don't.
Okay, my time is up. Thank you very much, Madam Chair.
Thank you, Mr. Pitts. Chair now recognizes Mr. Gordon for 5 minutes.
Thank you, Madam Chair. Last week, the President put forth a challenge to find ways to reduce the number of medical liability suits without capping malpractice awards. I agree with the President. I think if you're going to be able to try to get reduce the cost of health care, you've got to get all the inefficiencies out, and this is certainly one area. PricewaterhouseCoopers estimate there's $280 billion spent in defensive medicine. We can't wrench all that out, but surely there's some savings that can be made there. That's why I'm drafting medical malpractice reform alternative legislation responding to the President's challenge. The bill encourages states to step outside the box and test so-called alternatives like health courts and methods. It also I think that this will help lower the cost of defensive medicine, and I think it will compensate patients faster and be more fair. In my home state of Tennessee, we enacted a certificate of merit requirement last October that has already proven that there's been a 4% reduction in malpractice premiums. Earlier, you were all asked about whether you would think that malpractice reform should be a part of the overall reform, and you agreed. So I want to quickly ask you to say why and what savings you think we might be able to achieve. And Dr. Eberly, why don't we start with you?
First, I applaud you for doing this. I think it's the right step in the right direction.
Don't applaud me. Let's just move on and tell me why it's good. No. Tell me why. Please tell me why it's good.
Oh, okay. I think it's the step in the right direction. If there is not a relationship with patients, the default is to do more to patients, not less, so that you cover yourself. That's why the relationship is critical. If we don't get reform in place, then people that don't have that relationship will continue to order every test known to man to try to diagnose the problem.
I agree completely. I think the costs are hidden, but they are very, very real, and I think they're gigantic. Physicians order expensive tests to rule out conditions that they don't suspect but might occur randomly in one in several thousand. And if someone gets $10 million from a lawsuit and it occurs in an incidence of 1 in 10,000, if you don't screen for that, you're statistically going to lose money. And so you're exactly on target here. We must have real medical liability reform. I will tell you, in Georgia, in 2005, we enacted a very effective tort package. The number of suits in Georgia are down by 40% now. We only had 3 professional liability carriers in Georgia. We now have something like in the teens. And we have a cap on non-economic damages, not total damages, but only non-economic damages, so that economic
We're not talking about caps here. We're thinking about things less than that. Dr. Ehrlich?
I would agree that what both gentlemen before me said. The reality is that, having to pay some dollars out in those unfortunate circumstances is an actual cost, and without some relief from that, we will continue to bear those costs.
Dr. Wright?
I also agree. I think the burden of this is quite large, and I particularly like the idea that you would test various options, various approaches to controlling the tort problem.
Yeah, what we want to do is give incentives for states to experiment, and let's find out what might work. Dr. White?
The American Nurses Association does have some concerns about caps, and they have a position statement.
Again, we're not
that they
talking
can
about
make.
caps. I said practices short of caps.
Caps. Okay. Well, they have a position statement that they can make available to the committee.
But they would support malpractice reform short of caps. You raised your hand earlier.
Yes. Yes. I mean, it's as
Dr. Galbo.
As a governmental entity, we have governmental immunity, but in the broader discussion, I think that it's very important to do malpractice reform, and I think your idea of experimenting with health courts is a very good one.
Mr. Hawkins, earlier you said you weren't personally affected, but that's not the question. It's for the system as an overall.
Yeah, and as a matter of fact, if I can, one important thing that a couple of members of the committee here have sponsored legislation to extend the Federal Tort Claims Act, FTCA coverage, that health center clinicians get today to clinicians who volunteer at health centers.
Well, that'll be part of the bill in terms of emergency rooms. I think they should be considered as first responders.
I would just say we know for a fact.
And Mr. Yarwood. Oh, I'm sorry. Okay, I'm sorry. You're saying you know for a fact that it helps.
That many local physicians and clinicians would volunteer time at a health center if this issue were addressed.
Mr. Roberts.
I think from pharmacy's perspective, it's not as large an issue, but still we would be supportive.
Mr. Yarwood.
It's a huge issue. We've talked about this before, and include us.
Ms. Fox.
We absolutely agree.
And let me, if I could go back, since we have a little more time, concerning those individuals that have the hospitals. Are you finding it a problem now to get specialists to come into the emergency room because of the medical malpractice problem? Yes, ma'am, go ahead.
Because of medical malpractice, we aren't, because we have governmental immunity and our physicians are employed, so we have no problem getting coverage, and we don't pay extra for that coverage.
But it's because they're already covered. Yes. Okay, my time is up, and I thank you for your advice.
The chair now recognizes Mr. Shattuck for questions.
Thank you, Madam Chair. Dr. Wright, I want to begin with you. I also want to follow up with Dr. Ulrich because he mentioned a word that I think is very important. He talked about the incentives in the current policy or healthcare system. Under the tax code in America today, businesses can buy health insurance tax-free. Individuals have to buy it with after-tax dollars, making it at least 30% more expensive. You were just asked, and I want to follow up by a question by Mr. Pitts about transparency. I guess my concern about transparency is that until we enable consumers, individual people, to buy health insurance on the same tax-free basis that businesses can do it, I don't see how a consumer has the motivation to look at transparency. That is to say, if my employer provides me with health care and he or she pays for it, I don't see what the motivation is for me to go research the cost of a particular procedure at one hospital versus another, or one doctor for another, or the quality outcomes. Because I agree with you, I think that both cost and quality are things consumers want to know, but only if they're a part of a marketplace where those factors can make a difference to them. Would you agree?
I'm not a pricing expert. I am barely a quality of care expert. So I understand your point. I am greatly concerned about the number of people who are not covered at this point in time.
Me too.
I know you are. And so I guess most of my priority in terms of getting this fixed has been directed at them.
Dr. Ulrich, is that one of the incentives that concerns you?
Yes, certainly. And if I can expand on that just briefly.
Please.
if we look at the quality equation, that's the outcomes of patient care and the patient-physician and the patient-physician interaction being the numerator, cost being the denominator, quality being the end product of that. The concern I have is this, is that currently we don't pay for that. We absolutely need to move to that model. But what hinders us now is the fact that patients don't understand necessarily what quality is. We did some market research, and what patients tell us is that, look, you guys are all the same. You all went to medical school, you all did residencies, so there's really very little to pick between you. When in fact, for those of us that work in the industry, there are differences. So the question before us is, how do we now educate our patients so that they can make fully informed decisions relative to that quality equation?
Dr. Williamson, I think if I gather your testimony correctly, you think that's exactly the point. If we empowered or allowed, just permitted people to buy their own health insurance policy and therefore to shop for it and to be involved in the selection of the plan and the selection of the doctor, they would be motivated to use transparency, cost data, quality data, and make the market much more competitive, bringing down cost and causing quality to go up?
Absolutely, and I think it would raise quality on two levels. It would raise quality on the national level in terms of saving money in the entire system, and it would raise the quality that the individual patient perceives. Even though patients may not be able to judge scientific quality, they do vote with their feet. And I think if we had transparency, I think doctors are going to have to compete with each other. And if we can do what you have suggested, which is to empower patients to buy with the same tax advantage that employers have now, their own health insurance policies, and control that, then they control their medical decision making. That's the best way to keep costs down and ensure good patient care.
The health care policy I have advocated says that we should tell every American that has employer-provided health care that they can keep it and they can keep the exclusion. But every American that doesn't have employer-provided health care would get a tax credit. Those Americans who can't afford to buy their own health care would get a refundable and advanceable tax credit to go out in the market and buy what they want. We would then bring consumer choice to the entire healthcare industry. I'd like every member of the panel to tell me what other thing in our society somebody else buys for us. I mean, I struggle with this question, and I don't understand it. Our employers buy our health care insurance. They don't buy our auto insurance. They don't buy our homeowners insurance. They don't buy our suits. I don't buy my employees lunch. But why in healthcare do we decide that only employers can buy it? Is there something else that somebody on the panel can remember or can think of that is of that dimension, where your employer buys it for you and you're just kind of a pawn in the whole system? Dr. Williams?
I can't answer the question, but I can tell you where it came from, and it came from the notion of pooling risk. Patients realized that if I get really sick, I'm going to need a lot of money. And so they went together and they pooled their money, and then what happened is, over time, they've lost control of that pool of money. And that's where all this is coming from. Patients have turned over to others the ability to make their health care decisions for them by allowing them to pay for it.
So if we empower them to be able to buy their own health care if they choose it from their employer or out in the market, and we empower poor people to do that who can't afford it by giving them a refundable tax credit, we would also need to create new pooling mechanisms, would we not?
I completely agree with you.
Thank you very much.
Thank you very much, and I'll turn to Mr. Green for his questions. And I'll just say probably this is our last series of questions because the vote has been called, and your panel can be excused. You really set a record for endurance. I'll have to thank you, each of you.
Madam Chairman, some of us were here last night at 7 o'clock. Well, you were too, I think, and we realized started at 9:30 yesterday morning and finished sometime after 7.
Be thankful you weren't on that last panel.
Yeah, thank you. You'll at least get out before dark. Mr. Hawkins, as you know, I've been working with Representative Tim Murphy since we reauthorized Community Health Centers program last year on a bill we introduced, the Family Health Care Accessibility Act of 2009. The bill would extend Federal Tort Claims Act coverage to volunteers by deeming these volunteer practitioners at health centers as employees of the federal government. These volunteers would have to be licensed physician or licensed clinical psychologist and unpaid in order to qualify. This seems like an easy solution to the lack of primary care physicians in some areas, especially in medically underserved areas where community health centers are located. Yesterday, the GAO released a report stating that the lack of Federal Tort Claims Act coverage for volunteer practitioners can be a barrier for volunteers who wish to dedicate their time at a federally qualified health center. Can you elaborate on how the extension of the FTCA coverage to licensed physicians or other licensed practitioners would help increase the number of volunteers at federally qualified health centers.
Sure, Mr. Green, and thank you for raising that issue. In fact, just a couple of minutes ago, we were discussing the issue of malpractice, and I
hope my colleague, Congressman Murphy, was bringing it up.
That's okay. I specifically alluded to this legislation, which you and Mr. Murphy have collaborated on in the past and continue to collaborate on. I can't tell you, not only for primary care, Mr. Green, but even for urologists, dermatologists, you know, the biggest frustration that health center clinicians, who are virtually all primary care today, express is the barriers and difficulty they face getting specialty care, diagnostics, even hospital admits for the 7.5 million uninsured people we serve. In particular, not exclusively, but in particular, allowing FTCA coverage to extend to individuals who, as you note, come into the health center and donate their time, do not charge the patient, don't charge the health center, would be a phenomenal benefit and boon, and would provide for much more fully integrated care and better health outcomes.
And we discovered this problem in Texas with Hurricane Katrina with all the evacuees. In our federally qualified health centers, we had medical professionals who couldn't volunteer in Texas because they weren't covered. So, and we realize now that that's a way we can provide for our federally qualified health centers. The discussion draft also addresses the issue of residency training in off-site locations like FQHCs, but it still allocates the funds to the hospitals and not to the off-site locations. Do you believe language in the draft should make it easier for federally qualified health centers and other off-site residency training programs to start up and operate residency programs? And again, we have an example in my district of a federally qualified health center has a partnership with Baylor College of Medicine in Houston, and they do it. And what I'd like to do is see if we can get a number of medical schools, because I want primary care physicians to know they can make a living at a federally qualified health center in a community-based setting. So.
Not only that, Mr. Green, but I'm honored to be part of a panel today that includes Denver Health, the community health center, as well as a public hospital.
Congresswoman DeGette has preached to me for years about Denver.
All the joys and the great work that Dr. Gabeau has done. Also, residency training program. Marshfield Clinic, which has a community health center embedded in it, doing residency training. And Ted Epperly, Dr. Epperly, whose family medicine residency training program in Boise, Idaho, is also a federally qualified health center. Perfect examples. Now, all are working locally with their medical schools and with teaching hospitals to ensure, because those residents, even family medicine, have to have a med-surg residency inpatient-based, so it can't be done independently. At the same time, the vast bulk of family medicine residency training, pediatric residency training, even general internal medicine residency training can be done in an ambulatory care site. More than 300 health centers today across the country are engaged in residency training programs. They have rotations of residents through them, and everyone's willing to step up and do more. All that's needed is the resources to be able to do so.
Well, and if we know we need a chronic need for primary care doctors, then this is a way we can do that and hopefully expand it. One last question in my last 6 seconds. Discussion draft includes additional funding through the Public Health Investment Fund. And as many on the committee know, we've been asking for additional funds for federally qualified health clinics for years. How do you intend to use the new funds when you provide more services like dental and mental health, and will it also help build more FQHCs, because we know we need that in our country?
I think there are 2 or 3 quick points to make on that. Just last month, the Government Accountability Office, GAO, issued a report that pointed out that almost half of federally designated medically underserved areas in this country have no health centers, not a one. There are 60 million people out there today across this country, some of whom have insurance, and yet do not have a regular source of preventive and primary care. No family doctor, no medical or health care home. So the need is great. It runs in tandem with the extension of coverage that this bill would provide, but takes it that one step further, turning the promise of coverage into the reality of care through providing a health care home. The expansion of coverage to serve more people, as you noted, very importantly, the expansion of medical care to include oral health and mental health services, so crucially important. All of that will be afforded through the new resources in this bill.
And now, thank you again to the panelists, and we are in recess for the next panel to begin after this series of votes. It's 8 votes, but after the first one, apparently it's 2 minutes per vote, so it should go fairly quickly, hopefully. Thank you very much.
Good seeing you, Dan. Good job.